Good evening, esteemed colleagues, and thank you for joining us. My name is Dr. Bimnat, and I will be your moderator for today. It is my pleasure to introduce our speaker for today, Dr. Benoy Ambooken, orthodontist and dentofacial orthopedist, and also a certified Invisalign provider. He is a highly respected senior orthodontist with over 20 years of exclusive clinical experience and a sought after consultant in leading private dental clinics. In addition, he has been a dedicated educator conducting training programs across India, Sri Lanka, Thailand, and the UAE, and he has spoken at numerous international orthodontic conferences. Today's session is titled Clinical Tips for Fixed Orthodontic Practice. This insightful webinar will provide practical and clinical tips to enhance your fixed orthodontic practice. Before we start, I would like to inform you that this session is being recorded and the presentation may take 1.5 to 2 hours. Attendees can use the chat box for their questions, and there will be a question and answer session for the last 30 minutes after the presentation has ended. Attendees should also rename their devices to be able to take their certificates later on. Now we'll go to Dr. Benoy.
A very good evening to all the doctors. Myself, Dr. Benoy. Today, I'm going to present on the topic clinical tips to fixed orthodontic practice. I'm sure I'm presenting to one of the finest dentists of Ethiopia. To all the great dentists of Ethiopia, here I'm going to present on the topic of fixed orthodontics. As you all know, orthodontics has improved a lot based on the latest technology. Everyone wants to learn more and more on orthodontics to provide a better orthodontic care to your patients. So we have to update ourselves. What are the latest technology? What are the factors to be considered when you plan for your diagnosis, treatment plan, mechanics, and biomechanics? So before I start, I will tell 2 points regarding orthodontics. If you want to do good orthodontics, make sure you have ample of time. So you have to get a good amount of time from the patient, because orthodontics is not just a factor of simple bracketing, placement of the wire, doing some retraction. No, orthodontics has its own discipline. So in today's topic, I'm going to tell few clinical points which are relevant to orthodontic practice. And I'm sure it is going to be highly beneficial to each and everyone who are attending this program, because you could imply all the contents which I'm going to tell today directly into your practice from day after tomorrow, that is on Monday. So I'm not going to beat around the bush and take a lot of your time. I'm going to directly enter into my topic, that is on clinical tips to fixed orthodontic practice. We will see the diversity of orthodontic patients before we enter into the topic. What I'm going to tell you is regarding few of the cases. I'm sure many of the doctors here would have seen this case, because this was one of the cases. I presented it into our WhatsApp group today morning. I mentioned each and every step what is involved in this patient. So what I want to tell about this patient is, many a time when many of the doctors look into the case, what they are going to look is, should I do an extraction? Should I do a non-extraction? Is there any other methods of gaining space? No. In orthodontics, the first part to be considered is, what is the etiology of the problem? What caused the problem? So when you get a point on what is the diagnosis based on etiology, it becomes very easy for you to plan your treatment and to select your appliance. So when you check into this case, you could see a generalized spacing here. You could see a generalized spacing here. So in our content, what we are going to think is, how am I going to close that space? No. What I will always say as an orthodontist, before planning the treatment, look for the etiology. That is diagnosis. So the first clinical point in orthodontic practice is looking into the diagnosis, what caused the problem. So in this patient, the main problem is generalized spacing based on the patient. But for us, the main problem is the habit. So in this patient, there is a tongue thrusting problem. And we have to know at what age, I'll be telling in detail, at what age do we need to correct the tongue thrusting. So in this case, I've done with a self-ligating bracket. I got a beautiful finish, but the fact is, I diagnose the problem as tongue thrusting. How do you treat it? At what age? And how are you going to compromise that case? Everything has to be dealt step by step. So in that first case, what I wanted to say as the clinical point is, don't directly think of extraction or non-extraction. The first clinical point to keep in mind in orthodontic diagnosis is first find the etiology of the problem. Now, coming into another case, I'm sure everyone know what is this case. This is a bimaxillary dentoalveolar proclination. When you see a bimaxillary dentoalveolar proclination, everyone are happy. Why? Because everyone know in a bimaxillary dentoalveolar proclination, you are going to go for first premolar extraction. But I will always tell, though the diagnosis and treatment plan is easy, the mechanics has to be very careful when you plan for your bimaxillary proclination treatment. So I'll be telling you the correct wire sequence in fixed orthodontics. Let it be any case, at least you have to follow the correct wire sequence. Only then you can get a stable result at the end of the treatment. So the first clinical point I mentioned is look out for the etiology. In this case, I want to mention is after knowing the etiology, you have to check for the correct mechanics and biomechanics. In orthodontics, bonding of bracket is very important. Apart from that, bonding and banding, you have to be very careful with your wire sequence because orthodontics plays or give you a very good result if you can follow correct bonding and wire sequence. So the second point, what I mentioned is you have to always look into the mechanics and biomechanics of fixed orthodontics. Now, let us see another case. If you see into this case, what you find here is you get to see a patient who is coming to come with dental proclination. But the question is this a problem of dentition or is this a problem of skeletal base? I will always tell, don't just look into brackets or wire or extraction. In this, the main factor to be considered is this a case of fixed orthodontics or is this a case of interceptive orthodontics? So when you have a case reporting at the growth spurt, I'll be telling about the growth spurt, what is the difference between growth and growth spurt. But just to have an introduction, when you have a case coming during the growth spurt, you have to check into the skeletal malrelation. If you have a skeletal malrelation, it is very essential to correct the skeletal malrelation during the growth spurt so that you can get a beautiful maxillomandibular relationship. So many of the doctors are not even bothered to look into preventive and interceptive orthodontics. Many doctors are directly jumping into fixed orthodontics, that is corrective orthodontics. So the third case which I want to show you is that you get a lot of cases which should be categorized under interceptive orthodontics. I have forwarded a skeletal class 2 malrelation video. If you have gone through that, you will know you have various types of skeletal malrelation. This is a case of a retrognathic mandible. As you see here, the mandible is retrognathic and which certainly need a mandibular advancement with the help of a myofunctional appliance to get a perfect skeletal class 1 relationship. So the first case I mentioned was you need to understand the etiology. In the second case, I mentioned is that you should not only know the etiology, you should know the correct mechanics and biomechanics. In the third case, I mentioned you should not just look into fixed orthodontics, you should also look into preventive and interceptive orthodontics because in orthodontics, there is a lot to do during the growth spurt. Now, coming into another case, this is a case which reported with dental proclination. But this is not a case of dental proclination. This is a case of gummy smile. So during the younger age, do we have any treatment? Yes, there are a lot of treatment which need to be done during the growth spurt. Again, that tally to etiology and diagnosis. So a gummy smile patient with vertical maxillary excess, you see a vertical maxillary excess, can be treated during the growth spurt with the help of headgear face bow assembly. So you should be planning for correct diagnosis, correct treatment plan, correct phase of orthodontics, whether it is preventive orthodontics, whether it is interceptive orthodontics, whether it is corrective orthodontics or surgical orthodontics. And above all, you should be very careful regarding the bonding and the correct wire sequence. Now, coming into another case, this is a skeletal class 3. I'll be posting all these skeletal class 2, skeletal class 3 dental problem cases, everything into the clinical tip WhatsApp group, which is formed by EDPA in the following days. So you can have a thorough look into the step-by-step of treatment planning. So this is again a skeletal class 3. Don't do any wrong treatment with fixed orthodontics. Whenever you come across a skeletal problem at the younger age, it is your duty to correct the skeletal problem and then come into your dental correction. So this was a skeletal class 3 with a retrusive maxilla, which I have corrected it with the help of face mask, which is also called as a reverse pull headgear during the growth spurt. So only after the correction with the face mask, I have treated the patient further for dental problem. I've done a diamond bracket system whereby I was able to complete the entire treatment non-extraction. So how did I do it? It's just by correct diagnosis, correct treatment planning, and selection of the correct appliance. So why I am showing the diversity of orthodontics? Because orthodontics is not just fixed orthodontics. You have to play with preventive, interceptive, corrective, surgical orthodontics. All this matters when you finally come to the stability of the result. If you are not going for a correct diagnosis, if you are not following the correct sequence of bonding and wire placement, that is one of the main reasons you are ending up in relapse. So it is one-time treatment. You remember orthodontics like that. It is a one-time treatment. So you have to plan orthodontics rather than rushing into orthodontics or putting some chain or elastic chain or nickel titanium, closing the gap. That is not orthodontics. That is not the discipline of orthodontics. So we are going to go through the discipline of orthodontics. Since we have time, we will do it slow, but I'm just showing the diversity of orthodontics right now. Now, this is again another case, which is a skeletal class 3, which has a problem with the mandible, which has to be again treated at the correct age. I've treated it with the help of a chin cap, whereby I restricted and redirect the growth of mandible with the help of a chin cap during the growth spurt. Thereby, I got a beautiful skeletal correction. After the skeletal correction, it was easy for me to correct the dental problem. What many of the doctors do is that they directly jump into the correction of dental problem. You will not get a stable result. Sometimes you get a TMD, that is a temporomandibular disorder. All this can be avoided if you are following the discipline of orthodontics. So we need to look into what are the factors to be considered when you plan for orthodontics. So our session is starting from now. We have our first clinical tip. I have a lot of clinical tips to tell you today. And the last 2 clinical tips are the most important clinical tip. So it is very essential to stay with me to learn better orthodontics so that we can provide a better orthodontic care to our patients. So next time, since I showed you a lot of diversity, I showed you a spacing case, which was due to a tongue thrusting. I told you finalize what is the etiology. Second, I came into a case of bimaxillary proclination. Diagnosis is easy, but you have to be very careful in your bonding and especially in your wire sequence. Third case I showed you was a skeletal malrelation, skeletal class 2, whereby you have to advance the mandible with a myofunctional appliance during the growth spurt. The next case I showed you was of a vertical maxillary excess. That was a gummy smile patient, which I told you you have to treat it with the help of headgear face bow assembly. Another case I showed you was a retrusive maxilla, skeletal class 3, which I corrected with the help of a face mask. And later I treated with the help of a diamond system, that is a self-ligating system. I showed you another case of skeletal class 3 with a mandibular prognathism, which I intercepted with the help of a chin cap and later treated with the help of a fixed orthodontics. So orthodontics is not simple, but can be made simple if you go correctly in your diagnosis. So we are going to start with our first clinical tip. Few of the clinical tips I'm going to tell on the fundamentals of diagnosis. If you are sure with your diagnosis, your treatment plan becomes very easy. If your treatment plan is easy, you can select the correct orthodontic appliance. If you are selecting the correct orthodontic appliance, you have to know in depth of mechanics and biomechanics. Only then you're going to achieve a stable orthodontic result. Thereby, you're doing something good to your patient. At the same time, your result should last. That is the orthodontic. Many of the doctors will think that, okay, I've got a beautiful result. What we say here is that I want a beautiful result which is going to be stable. So we need to plan for a stable orthodontic result. For that, we have to follow certain steps. In that, the first step is when you get a patient at the younger age, you have to check whether the patient is coming under preventive orthodontics, or the patient is coming under interceptive orthodontics, or the patient is coming under corrective orthodontics. If you miss your preventive and interceptive orthodontics, directly you're pushing the patient into surgical orthodontics. So don't push a patient into surgical orthodontics, or don't compromise the result with corrective orthodontics. So what is preventive orthodontics? Any procedures you are doing to prevent any malocclusion, like we will tell space maintainers, your parent education, caries control, then your habit breaking appliances, all comes under preventive orthodontics. So you have to check into your patient in depth. Maybe the patient may be coming for a deciduous teeth extraction or some dental pain. Any young patient come to your clinic, you have to check for preventive orthodontics. As I mentioned, it can be a parent education, caries control, space maintainer, oral habits like tongue thrusting, mouth breathing, thumb sucking, bruxism. All these are oral habits which has to be prevented before it develops into a malocclusion. Now, what is interceptive orthodontics? Interceptive orthodontics, the problem has already started. You are trying certain procedures to prevent the severity of the problem. Like you are doing some myofunctional orthopedic appliance, you are minimizing the skeletal malrelation, space regainers, single tooth correction, all comes under interceptive orthodontics. So, interceptive orthodontics and preventive orthodontics should be incorporated into your practice so that you can minimize the corrective orthodontic problem. At the same time, you can minimize surgical orthodontics. And I know everyone knows about corrective orthodontics. I'll be mentioning the wire sequence, what are the factors to be considered in the stages of aligning, leveling, space closure, finishing, and detailing. So we will start our session first with few points of preventive orthodontics. And doctors, you have any doubt, you can comment that in your chat box. At the end of the session, I will be taking individual doubts. I'm sure EDPA will help me regarding that. But you have any doubts, you keep mentioning it in the chat box so that I'll be able to take up all the doubts at the end of the session. So I'm going to tell few points regarding preventive orthodontics. In preventive orthodontics, one of the major problems what we come across are oral habits. Many doctors are not bothered about oral habits. They just, as I mentioned, we are delaying the case. We are telling many of our patients, you come at the age of 12, I'm going to do MBT, straight wire system, or some doctors who are even well versed, they will tell, okay, I will do a self-ligating diamond system, or some doctors with the latest technology, they will tell, okay, I'm going to do a lot of clear aligners. Everything is good. But is that very essential to do all these type of appliances, or it can be treated simple during the corrective orthodontics, during the preventive orthodontics phase is another question mark. So I'm going to tell a few points on oral habits, which is very essential for every doctors to know and implement in your practice at the earliest. The advantage is you can reduce the severity of the dental problems. The common oral habits which many of us don't attend is tongue thrusting. Many patients comes with a problem of dental proclination, spacing, open bite. Some patients come with a narrow arch. All this can be some of the clinical effects of tongue thrusting. So when you have a tongue thrusting patient, the first part, as I mentioned, is diagnosis. How do you diagnose a case of tongue thrusting? That's something very important to keep in mind. Now, whenever you get a case of tongue thrusting, the best common diagnosis is lower lip pull test. What we need to do is that we need to pull the lower lip of the patient. We need to pull the lower lip of the patient and ask the patient to swallow. You will see straining of the upper lip. The upper lip, when it gets strained, you will get the lower lip getting elevated and you will see straining of the upper lip. So you will find you will find three signs when you do a lower lip pull test. One is when you pull the lower lip, the patient try to swallow. In a tongue thrusting patient, the patient will try to strain the upper lip so that the patient can get a lip seal. Second is, since you pull the lower lip, patient will try to pull the lower lip such that it can touch with the upper lip. So you will feel the pressure on the lower lip. At the same time, you can see the patient highly thrusting the tongue between the upper and lower teeth. So if you see these three features during the lower lip pull test, it's an indication the patient is having tongue thrusting. So I'm going to replay that video so you can certainly look and appreciate on lower lip pull test. So you pull the lower lip, you see straining of the upper lip, you see the pressure on the lower lip, and you see the patient trying to thrust the tongue. If you see these effects during the lower lip pull test, it is an indication the patient is having tongue thrusting. Always remember, between the age of 6 to 10 years, between the age of 6 to 10 years is the ideal time to plan for preventive orthodontics. In preventive orthodontics, a patient reporting with a tongue thrusting should be treated with a fixed tongue grip, minimum for 9 months. So, whenever you have come across a case of generalized spacing, your dental proclination, open bite, narrow arch, suspect tongue thrusting, do the lower lip pull test. If the lower lip pull test is positive, if the patient is between the age of 6 to 10 years, 100% you have to treat the tongue thrusting. You can take an upper lower impression, you can give it to a lab, you can plan for a fixed tongue grip, minimum time of 9 months. If you see into this case, I got a patient having increased open bite. I've just given a tongue grip. You can appreciate the result after approximately 8 months. You can see the entire open bite has closed. Now it is very easy for me to treat because I've corrected the oral habits. Now I have to correct only the dental problem. So I got a lot of spacing. So I can easily attempt my fixed orthodontic appliance, non-extraction. So correct diagnosis at the correct age can save a child, especially diagnosing in the preventive orthodontics part. So the first point I will mention is next time a patient coming with open bite, proclination, your spacing, posterior cross bite, lower lip pull test positive, plan for an oral habit breaking appliance. In a tongue thrusting patient, you have to plan for a fixed tongue grip. You have to maintain that fixed tongue grip for minimum of 9 months. Ideal age is between 6 to 10 years. Now, you also get a lot of patients with mouth breathing. Many a time, many patients report to our clinic stating that I have a lot of dental decay, especially the anterior teeth, anterior marginal gingivitis. You can also see on these type of patients, you see long narrow face, narrow nostrils, short upper lip, increased incisor visibility, anterior marginal gingivitis, multiple caries. Make sure you refer this patient to ENT. Why? Because there are a lot of anatomical reasons, and ENT has to find out, that is the ear, nose, throat specialist, have to find out what is the problem, what is the anatomical reason for mouth breathing. Only after considering the ENT specialist, you have to take up that patient for treating the mouth breathing. Here, you have a lot of muscle exercises, or you also have an appliance called as an oral screen, which also gives you a result. Though oral screen is not a 100% result provider, but it can convert a mouth breather into a oronasal breather. So next time, remember the 2 points which I just mentioned. A young child coming to your clinic, they may be coming for dental restoration, they may be coming for early extraction, whatever may be the reason. You come across a tongue thrusting patient, do the lower lip pull test. If it is positive, you have to give a fixed tongue grip between the age of 6 to 10 years, minimum for 9 months, and you should get your open bite into a deep bite. Once your habit is broken, you can easily plan for a fixed orthodontic treatment later so that the result is going to be stable. Another common oral habits which many of us miss is the mouth breathing. You get to see any patients coming with long, narrow face, narrow nostrils, short upper lip, increased incisor visibility, multiple dental decay, anterior marginal gingivitis, proclination, all you should consult is first a ENT specialist. Only after ruling out the anatomical problem, you are going to plan for your oral habit breaking appliance, that is an oral screen, and only after correcting the oral habit, you should plan for fixed orthodontic treatment. So the first point to keep in mind, diagnose, treat the etiology at the younger age, especially for children, so that you can have a stable result with fixed orthodontic treatment during corrective orthodontic part. Now, I posted few videos on skeletal class 2 and class 3. Yesterday, Dr. Meron has posted into the EDPA group. You should certainly go through skeletal class 2 and class 3 malrelation, because many doctors even have very little idea on how to correct a skeletal class 2 and class 3. No problem. But at least you should have a thorough knowledge on at least how to diagnose a skeletal class 2 and class 3. And lateral ceph is very essential. Whenever you are in a doubt, the supplemental diagnostic aid, that is a lateral ceph, is very essential to diagnose whether the patient is a skeletal class 2 or a skeletal class 3. If you come across a skeletal class 2 or a skeletal class 3 during the growth spurt, you have to do interceptive orthodontics, because your myofunctional and orthopedic appliances are going to do a very good result for your skeletal malrelation correction. So I'm not reposting the video, but it is already there in the group, I guess. Dr. Meron yesterday should have posted to the group about a skeletal class 2 and a class 3. And today morning also I posted on skeletal class 2 and class 3. If required, I will repost it. If anyone have not gone through, you can join with the clinical tip WhatsApp group. Many of the doctors have joined, but I will certainly suggest doctors to join with the clinical tip WhatsApp group. Why? Because you get to know lot of clinical points which could be implemented to your practice by joining to that group. So it has been held with EDPA. So EDPA is going to manage that clinical tip group. But the advantage for all the doctors is that you can upgrade yourself in the field of orthodontics. Now, when you come into skeletal class 2, you get to see lot of skeletal malrelation, and you have lot of skeletal class 2 components. When you come across a maxillary normal, and when you have a retrognathic mandible, that is the time you're going to advance the mandible. So a skeletal class 2 with normal maxilla and retrognathic mandible should be advanced during the growth spurt with the help of a myofunctional appliance. Commonly, we have a lot of myofunctional appliance like a twin block, you have a frangle, you have Herbst appliance, you have advancing, lot of myofunctional, removable, fixed, and hybrid myofunctional appliance are available. But the target is you have to diagnose when? During the growth spurt. Now, I've been telling about the growth spurt to practice myofunctional appliance. The timing to practice a myofunctional appliance for girls is between 11 to 13, and for boys between the age of 14 to 16. That is considered as the peak velocity of growth. So when you come across a skeletal class 2 with retrognathic mandible and you are in a doubt, don't hesitate to take a lateral ceph. Once after taking lateral ceph and you diagnose it as a skeletal class 2 with a retrognathic mandible, it is your duty to advance the mandible with the myofunctional appliance, as I just mentioned right now, during the growth spurt. That is for girls between the age of 11 to 13, boys between the age of 14 to 16. Now, you have another skeletal class 2 component where you have the maxilla problem. You have a skeletal class 2 with a prognathic maxilla, and you have a normal mandible. That's called as an orthognathic mandible. You have no issue with the mandible. Your entire problem is with the maxilla. That is the time you're going to plan for orthopedic appliance, where you're going to restrict and redirect the growth of maxilla with the help of headgear. That's the one which I just mentioned earlier. Headgear phase bow assembly practice during the growth spurt, that is during the mixed dentition growth spurt. Orthopedic appliances are practiced during the mixed dentition growth spurt. Girls between the age of 7 to 9, boys between the age of 8 to 11 years. So don't confuse. When you have a skeletal class 2 with mandible problem, advance the mandible with the help of myofunctional appliance like a twin block, or you can have a Herbst appliance during the growth spurt. That is the mixed, that is during the your prepubertal growth spurt, girls of 11 to 13, boys of 14 to 16. You can correct the skeletal class 2 malrelation. When you have a maxilla problem, you have to correct it with the help of orthopedic appliance. That is a headgear. Headgear during the mixed dentition growth spurt, girls of 7 to 9, boys of 8 to 11 years. So your diagnosis does matter. If you can save the child by proper diagnosis, correct the preventive part and correct the interceptive part. You have a third problem with skeletal class 2, that is vertical maxillary excess. That's why I just mentioned about the vertical maxillary excess, the gummy smile. Again, treated with the help of orthopedic appliance, that is a headgear face bow assembly, practiced during the mixed dentition growth spurt, that is girls of 7 to 9, boys of 8 to 11 years. And the fourth component is a combination problem. What is a combination problem? You have your maxilla, which is very prognathic, and your mandible is very retrognathic. That is the time we practice combination appliance. That is, headgear is incorporated into a twin block. Orthopedic appliance is incorporated into a myofunctional appliance. So, what I mentioned till now is we have a lot of diversity of orthodontic cases. You have to plan for a proper diagnosis based on etiology. You have to have a thorough knowledge on the appliance selection. You have to know proper on bonding. You have to know the entire mechanics and biomechanics, follow the correct wire sequence. When you plan orthodontics, you have to plan based on preventive orthodontics, interceptive orthodontics, corrective orthodontics, and surgical orthodontics. In preventive orthodontics, at least take care of the habit. Why? Because if the habit persists, you will not get a stable result at the end of fixed orthodontic treatment. The two habits which I mentioned is, one is tongue thrusting, which you can diagnose with the lower lip pull test. You can treat it with the help of fixed tongue grip between the age of 6 to 10 years. Minimum time of wear of fixed tongue grip is 9 months. You should get your open bite into an ideal bite or deep bite. That is more advantage. Also, remember about mouth breathing. A patient coming to you with long face, narrow nostrils, you have your incompetent lips, that is short lip, increased incisor visibility, multiple dental decay, consider an ENT specialist, and only then take up the case for your oral screen or various muscle exercises. Also, be very careful to correct the skeletal class 2 and skeletal class 3, that is during the interceptive orthodontics. As I mentioned, skeletal class 2 comes in 4 components. When you have your mandible problem, that is your mandible is retrognathic, or you are in a doubt whether it is a skeletal problem, don't hesitate to take a lateral ceph. Once you have your lateral ceph and you diagnose it as a skeletal class 2 with a mandible problem, don't hesitate to practice your myofunctional appliance between the age I mentioned, that is during the prepubertal growth spurt, 11 to 13 for girls and 14 to 16 for boys. When you have your maxilla problem, your maxilla is very prognathic. When you come to know through your lateral ceph, don't hesitate. You have to practice headgear, that is an orthopedic appliance. At what age? Girls of 7 to 9 and boys of 8 to 11 years. You have your vertical maxillary excess gummy smile. You have to treat it at the correct age, that is during the mixed dentition growth spurt with the help of headgear face bow assembly. Again, in your lateral ceph, if you come to know you have a combination problem of maxilla as well as mandible, it is treated with the help of a combination appliance, that is headgear is incorporated into twin block. In one word, we'll tell orthopedic appliance is incorporated into a myofunctional appliance. So don't miss this treatment, because by missing this treatment, we are doing a crime to our patient. That's what, as an orthodontist, I will tell, we are doing a crime. Just because we are not aware, we are telling, no, I didn't know, so I didn't do that treatment for you. And altogether, who's going to suffer? Not the dentist, it is the patient. So it is high time, if you are staying still with your original or the traditional method of fixed orthodontic, no, it is high time for each and every one of us to upgrade ourselves so that we can provide a better orthodontic treatment to our patients. Now, we are coming into the clinical tip 2. So the clinical tip 1 I mentioned is on preventive part, and also I mentioned is upon you should have a great idea on interceptive orthodontic part. I'll be posting these videos to the group. Again, every day I'll be posting the clinical tip. Don't hesitate to look through all these clinical tips so that you can upgrade yourself in the field of orthodontics. Now, I'm coming into the clinical tip 2. As I mentioned, we are always looking intraorally. we are looking into whether there is a deep bite, whether there is a proclination, whether there is spacing, or is there any impacted teeth? No. In orthodontics, you have to first evaluate the soft tissue. Soft tissue in sense, we have to look into the nose, the chin, cheeks, lips. The soft tissue does matter. So if you are looking into the etiology or diagnosis, first look into the soft tissue of the patient. Especially when we consider the facial soft tissue, you have to consider the lips. Because many a patient will tell, when they consider the lips, they will tell, I have a dental proclination and I want fixed orthodontic treatment and I want retraction. Why? Because my lips are not closing. So they assume, I'll tell, they will assume that their lips are not closing because of dental proclination. Is that true? That's a question mark. So lips are incompetent not only because of dental proclination. There are a lot of etiology for lips being not competent. So when we look into it, why the lips are not closing, you have to consider various etiology for lip not being competent. So first etiology, if you check into, you will see proclined upper anteriors, at the same time increased clinical crown height. That is something related with the dentition. That is a time you can practice orthodontic appliance. What is orthodontic? Correcting the teeth. So remember, dental problem, select orthodontic appliance. Your lips will not close if you even have a maxillary or prognathism or vertical maxillary excess. I told you skeletal problem. Skeletal problem has to be addressed during the interceptive phase. So your lips will not close even if your etiology is prognathic maxilla. At the same time, if it is vertical maxillary excess, so that should not be treated with an orthodontic appliance. What is orthodontic? Correcting the teeth. If you have a skeletal problem at the younger age, you should treat it with the help of orthopedic appliance like a headgear. And sometimes you will also have short upper lip, which need to be corrected with the help of a myofunctional appliance. So next time, if a patient is coming to your clinic and telling, doctor, I want fixed orthodontics or I want braces, they will tell in their layman term, they will tell, I want a braces and ready for extraction. No. First thing, check why their lips are incompetent. It is not only because of dental proclination that lips are incompetent. If it is due to dental proclination and increased clinical crown height, you can select orthodontic appliance. Like you can select an MBT system, you can select a self-ligating system, you can even select a clear aligner. Everything is fine. But if your diagnosis goes wrong, maybe if the problem is due to prognathic maxilla, the lips are not closing, or is it because of vertical maxillary excess, the lips are not closing, and you accidentally select a wrong appliance like a fixed orthodontics, it is not going to get you a result. That is why many of the cases are getting compromised. Why compromise? Because we are going wrong in our diagnosis. So remember, lips are incompetent not because of only dental proclination. You have various other factors to be considered when you plan for your appliance selection. Now, when we come across another main problem is the gummy smile. Many patients, especially in India, they consider gummy smile is not aesthetic. They will tell, doctor, I have a gummy smile problem. And many doctors are there directly on hearing gummy smile. They will directly go for fixed orthodontic. Is that correct? It's a question mark. Now, when will we tell that I have a gummy smile? During a full smile, that is during a dynamic smile, if your gums are visible by more than 2 millimeter, if your gums are visible by more than 2 millimeter, that is the time we will tell it is a gummy smile. So what I've been telling till now is we have to diagnose the preventive orthodontic part, that is tongue thrusting, your mouth breathing. You get a patient, you have to check for whether there is a skeletal problem, and it has to be corrected in the interceptive part, skeletal class 2 and class 3. When in doubt, don't hesitate to take a lateral ceph. And the third, when we consider a corrective orthodontic part, don't just directly look into dentition. You have to look into the soft tissue. In that soft tissue, first thing is evaluating the lips. When a patient is telling my lips are not closing, don't think it is only because of dental. As I mentioned, there are a lot of factors to be considered apart from dental. Sometimes your lips are not closing because of the dental problem, sometimes a skeletal problem, sometimes a soft tissue problem. Now, as we have mentioned about the gummy smile, again, gummy smile is not 100% to be corrected with fixed orthodontics. Why? Because There are a lot of etiology when you plan for your gummy smile. The etiology starts from vertical maxillary excess, or it can be maxillary protrusion, short upper lip, short clinical crown height, altered delayed passive eruption, hypermobility of upper lip. Lot of etiology persists when the patient report to you with gummy smile. Now, based on the etiology, see a lot of etiology you could see here, and I've written a lot of treatment. But what is the role of orthodontics in correcting the gummy smile? That's a question mark. So commonly, when you plan for gummy smile correction with orthodontics, you can get a beautiful result if your gummy smile is between 2 to 4 millimeter. The rule of orthodontics to correct the gummy smile is when you plan for intrusion, when you intrude the teeth, your 1 mm of intrusion of upper anteriors will reduce the gummy smile by 0.66 millimeter. So the rule is 1 mm intrusion will reduce your gummy smile by 0.66 millimeter. The total intrusion you can achieve is 4 millimeter. So 4 into 0.66 of gummy smile can be corrected with fixed orthodontic treatment. So I will repeat, a gummy smile based on the etiology, you have a lot of etiology, but based on the etiology, if you check out, you don't see any of the fixed orthodontic appliance. You see only orthopedic appliance, biofunctional appliance, surgical crown lengthening, gingivectomy, Botox. Where is the role of orthodontics? Yes, you can correct gummy smile with fixed orthodontics. If you have a gummy smile on an average of 2 to 4 millimeters with fixed orthodontics, you can intrude your anterior at the same time. As I will show with my hand, if this is the teeth and my sleeves are the gingiva, as I intrude my teeth by 1 millimeter, the gingiva will move apically by 0.66 millimeter. The maximum intrusion I can achieve is 4 millimeter. So the maximum gummy smile I can reduce is 4 into 0.66. So next time you get a patient with a gummy smile of 2 to 4 millimeter, you can correct that gummy smile with fixed orthodontic, but fixed orthodontic should help you in anterior intrusion. That's very essential. At the same time, presently, if you ask me, how do you correct more gummy smile? I will tell, I'm a big fan of mini implants. Your orthodontic dental mini implants will get you a beautiful result for gummy smile because mini implants are going to give you an absolute intrusion of upper anterior. The upper anterior intrusion is reducing the gummy smile. Hence, I will suggest if you are planning or your patient is reporting with a lot of gummy smile and your patient is not ready for any surgical correction, don't hesitate. You can correct your gummy smile approximately of 4 to 8 millimeter with the help of orthodontic mini implant. So I repeat, next time a patient is coming to your clinic and telling that I have a dental proclination, that's my lip not closing. No, you have to check the etiology, whether it is dental proclination or is it because of short lip, or is it because of increased crown height, or is it because of prognathic maxilla, or is it because of short lip. Based on the etiology, you have to select the appliance. Same way, whenever a patient report you with gummy smile, don't think orthodontics alone is the treatment part. You have a lot of treatment part when you consider your gummy smile, but you can correct your gummy smile of 2 to 4 millimeter with the help of orthodontic intrusion. As I mentioned, you can do an intrusion of 0.66 millimeters, or you can do an intrusion of 1 millimeter. Your gum will go apical by 0.66 millimeter. So maximum intrusion is 4 millimeter. So 4 into 0.66 is the maximum gummy smile you can reduce with regular fixed orthodontics. But if you can incorporate an orthodontic mini implant, you can get a better gummy smile correction. You can intrude more than 4 millimeter, and as the teeth intrude, your gums are going to shift apically, thereby reducing your gummy smile. So next time, remember, gummy smile, the best treatment option is anterior mini implant. Now, when you come across these cases and all, you see this patient reported with severe gummy smile. I've done a first premolar extraction. I got a beautiful result with the help of orthodontic mini implant. I'll be posting all these cases to the group. I'll get a beautiful result with an orthodontic mini implant. You can clearly appreciate the visibility of the dentition, and it has reduced the gum visibility. So, gummy smile is treated with orthodontic mini implant. by placing the mini implant in the anterior region. Intrusion is highly appreciated. By intruding the anteriors, you can reduce your gummy smile. So the points to consider till now is that remember a proper diagnosis starting from the younger age. Don't make the patient delay till the age of 12. You have a variety of ortho cases starting with your spacing, your bimaxillary proclination, skeletal malrelation, oral habits like your mouth breathing, tongue thrusting, skeletal class 2 and skeletal class 3, which has to be treated in the interceptive orthodontic part. A patient, when they comes for your orthodontic treatment, don't just look into dental. You also have to look into the soft tissue. In the soft tissue, I mentioned about the lips. I also mentioned about the gummy smile. Gummy smile, the best treatment option comes to you with the help of anterior orthodontic mini implant. And how much is the maximum intrusion possible? I mentioned 4 mm. For each millimeter of anterior intrusion, you can reduce the gummy smile by 0.66 millimeter. Now, when you come into the clinical tip 3, so we have a lot of clinical tips to follow, but when you come into the clinical tip 3, are you sure you are following each and every step of fixed orthodontics, or you are just doing a regular aligning? I've seen a lot of doctors, when no, I'm not blaming anyone. Being an orthodontist, I should certainly say I've seen a lot of doctors learning from YouTube. I've seen them visualizing, doing some just the braces, nickel titanium wire, each and from molar to molar. You are disturbing the occlusion. You are disturbing the TMD. You are disturbing the aesthetics, and lifelong the patient is going to suffer just because we didn't follow the discipline of orthodontics. So don't treat orthodontics in a way you can do anything with the help of nickel titanium wire and e-chain. No, that's not orthodontics. Orthodontics has its own credibility. If you are planning to do good orthodontics, you should follow each and every step of orthodontics. That's why in the beginning stage I mentioned, you want to do good orthodontics, you have to buy the time from the patient, not the money. You buy the time from the patient, you can do beautiful orthodontics if you're good in your diagnosis, bonding, and wire sequence. So commonly, I'm sure everyone know what is an aligning stage. Commonly, I'll be coming in detail into it, but commonly we do the aligning on round nickel titanium wire. The leveling, I'll be doing it on a rectangular nickel titanium wire. Retraction, I'll be doing on rectangular stainless steel. I'll be telling you which wires in the forthcoming clinical tip. Finishing, I have to do it on rectangular stainless steel. Retention, I'll be telling you which are the cases that you need to have your Holly's retainer, which are the cases you're going to go for fixed lingual retainer, which are the cases you're going to go for clear retainer, that is the A6 retainer, and then follow. So orthodontics follow the steps: aligning, round nickel titanium wire; leveling, rectangular nickel titanium wire; retraction, rectangular stainless steel; finishing, rectangular stainless steel; detailing, a round stainless steel or a round nickel titanium wire, and then comes to your retention. So you are doing orthodontics. After your diagnosis, your bonding should be correct, your wire sequence should be correct. You have to follow each and every step of orthodontics so that you can provide a quality orthodontic treatment to your patient. As I mentioned, we don't just want a result, we want is a stable result. If you want to get a stable result, you should follow each and every step of orthodontics with the correct wire sequence. I'll be telling you the correct wire sequence today in this webinar. So stay tuned. And then when we come across, why I'm telling about a deep bite is that many of the doctors don't do a proper leveling stage. What is a leveling stage? You're going to level the caroscopy. That means you're going to correct the deep bite. If you don't correct the deep bite, that is one of the main reason for relapse. Why? Because many doctors don't even diagnose the deep bite. We have to be very careful in the second stage. Aligning is comparatively easy. I'll be telling you the clinical points on aligning, but I will tell you the leveling is slightly a difficult stage. Many a time, many doctors don't do the leveling stage. That is with the help of a rectangular nickel titanium wire. If you don't do proper leveling stage, you are not leveling the caroscopy. That means you are not correcting the deep bite. Before I tell you how to correct a deep bite, you should know what is a deep bite and what are the different types of deep bite. Now, you come across a deep bite, you should know you have a skeletal deep bite as well as you have a dental deep bite. That's the first thing you have to know. Whether the deep bite is always dental, no. Sometimes the deep bite can be even skeletal. What are the three types of skeletal deep bite? The first is you will not see any visibility of lower anterior. That means your lower anteriors are completely hidden by the upper anterior. That means to say it is a 100% deep bite. That's a skeletal deep bite, which has to be corrected either in the interceptive orthodontic phase or in the surgical phase. You cannot correct a skeletal 100% deep bite with the help of fixed orthodontics. So case one is a skeletal deep bite where there is no visibility of lower anterior. That's a skeletal deep bite. The second skeletal deep bite is you have an increased overjet. You have an increased overjet and your lower teeth is hitting with the soft tissue of the upper. That is, it is hitting on the palatal soft tissue. That's also a skeletal deep bite, which has to be again corrected in the interceptive phase or in the surgical phase. You cannot correct a skeletal class 2 deep bite with the help of fixed orthodontics. And third, you will see no visibility of upper anterior. That is in a skeletal class 3. So if you come across these three types of skeletal deep bite, that is, you have your no visibility of lower anterior, increased overjet with the lower teeth hitting the soft tissue of the upper. And the third skeletal deep bite is that there is no visibility of upper anterior. You cannot correct the skeletal deep bite in fixed orthodontics. Don't waste your time. Why? Because this should have been corrected in the interceptive orthodontic phase, not in the corrective orthodontic phase. But you can correct the dental deep bites in the fixed orthodontic phase. What are the two types of dental deep bite? You come across a pseudo dental deep bite and you come across a true dental deep bite. In a pseudo dental deep bite, you will see well erupted molars. Your molars are well erupted. You have a well erupted molar. You have an acceptable central incisor clinical crown height. It is your target. You can correct a pseudo dental deep bite during fixed orthodontics by intrusion of upper and lower anterior. So a pseudo dental deep bite with well erupted molar having a deep bite should be corrected by intrusion of upper and lower anterior during fixed orthodontic treatment. When you have a true dental deep bite, what is a true dental deep bite? You have reduced molar height. Your molar height is very less, but you still have a deep bite. This is the case where you have to extrude your posterior. That means to say, you're going to extrude your posterior with the help of anterior bite plane at the younger age. When you extrude your posteriors, what happened to your mandible? Your mandible rotates downward and backward. So, when you come across a deep bite, first you have to select whether it is a skeletal deep bite or it is a dental deep bite. I told you there are three types of skeletal deep bite which cannot be corrected with fixed orthodontics. You have to correct it with the help of interceptive orthodontics. But when you come across two types of dental deep bite, that can be a pseudo dental deep bite or it can be a true dental deep bite, you can correct your pseudo dental deep bite, that is a well erupted molar, but still you have a deep bite. You can intrude your upper and lower anterior during fixed orthodontic treatment. Pseudo dental deep bite can be corrected. But when you have a true dental deep bite, reduce molar height, you have to target your posteriors to extrude the posteriors with the help of anterior bite plane, or there are a lot of other appliances available to extrude your posterior. Once you extrude your posterior, what happened to the vertical dimension? Your mandible is going to rotate downward and backward. As the mandible rotates downward and backward, your vertical dimension increases and that will also reduce your deep bite. Now, if you're getting confused with your dental deep bite, the easy clinical tip is never ever extrude your posteriors in a long face patient. If you have a long face, that is a dolichofacial patient who is having a high angle, don't try to extrude your posteriors. That is the time you have to intrude your upper and lower anterior. So next time, never give an anterior bite plane for a long face patient. A long face patient, you are going to correct the dental deep bite during fixed orthodontic treatment by intrusion of upper and lower anterior. You can do your reverse curve nickel titanium wire, or you can even give your anterior mini implant to correct your dental deep bite, which is a pseudo dental deep bite. So long face patients never extrude the molar. Long face patient should be corrected your dental deep bite by intrusion of upper and lower anterior. So long face patients fall under pseudo dental deep bite, where you're going to intrude your upper and lower anterior. But when you come across a round face patient, you have to see a round face brachyfacial patient, low angle cases, you have to plan to extrude your posteriors. You can plan your anterior bite plane or various other molar extrusion methods are there. By extruding the molar, as I mentioned, you're going to increase the lower facial height and your mandible is going to rotate downward and backward, which is going to correct your true dental deep bite. So just to recap on the topics which I just mentioned, I showed you diversity of cases. In that, the first clinical point I told is don't first plan the appliance. First plan to know what is the etiology. Based on the etiology, plan for your diagnosis and treatment plan. Don't forget to select the correct appliance. I'll be telling you what are the various appliances available today. Select the correct appliance. Once you select the correct appliance, you should know what is the correct mechanics and biomechanics. And also, if you're planning to do fixed orthodontics, you have to start the stages from aligning, leveling, space closure, finishing, detailing, retention, following the correct wire sequence. I'll be telling you the wire sequence today. I also mentioned whenever you come across a skeletal class 2 and class 3, during the growth spurt, that is during interceptive orthodontics, you have to correct the skeletal malrelation either with the help of myofunctional appliance or with the help of orthopedic appliance. I also looked into, you should never directly look into the hard tissue, that is the dentition. You should also look into the soft tissue. Is there something related with lips? Is the dental proclination alone is the reason for your lip incompetence? No. I mentioned various etiology of lip incompetence. Based on the etiology, you have to select the appliance. I also told you about the gummy smile. If your gums are visible more than 2 millimeter during dynamic smile, that is a full smile, you have to plan for correction of the gummy smile. I told you a lot of etiology is there, but based on your orthodontic correction, by intruding the anteriors, you can correct your gummy smile. Maximum intrusion possible is 4 millimeter. 1 mm intrusion, your gummy smile is going to reduce by 0.66 millimeter. You can get a beautiful result of gummy smile with the help of anterior mini implants. I also mentioned you regarding your deep bite. Don't hesitate to correct the deep bite because many a time orthodontic relapse is happening because of the iatrogenic deep bite. Many doctors do, just as I mentioned, bracketing, YouTube video, your nickel titanium, E-chain, everything is going to collapse the occlusion of the patient, which should not be done. As a dentist, we are having a lot of duty to perform to our patient. In that, I mentioned about the deep bite. You have your skeletal deep bite or your dental deep bite. In your dental deep bite, long face patient, never extrude the posterior. In long face patient, you have to intrude your anterior. Either you can use a reverse curve nickel titanium wire or your anterior mini implant. At the same time, if you have a round face, reduced molar height, that is a situation you have to extrude your posteriors in a low angle case, that is a brachyfacial patient, low angle case, horizontal grower, you are going to extrude your posteriors. By extruding the posteriors, you're going to increase the vertical dimension and you're going to clockwise, anti-clockwise rotate your mandible and you can improve the facial proportion also. Now, coming into when you plan your treatment, as I mentioned, you should check into preventive orthodontics, treat the habits like your tongue thrusting, your mouth breathing, your bruxism, your thumb sucking, everything has to be treated in the preventive part. At the same time, you should also look into the skeletal malrelation correction. The skeletal malrelation correction, as I mentioned, during the growth spurt, you have to inform the patient and the parent that you're having skeletal problem, which has to be corrected during the growth spurt. Based on your diagnosis, the patient is informed, you are in a doubt, you have to take a lateral ceph, diagnose it, treat it well. Hence, you will get a stable result later when you do fixed orthodontic treatment. Before I go into the next clinical tip, just for a small information, in collaboration with EDPA, we, the dental experts, I'm sure you're very well aware of all these doctors who are present here. I'm sure you all know about Dr. Yaya, Dr. Satyun, and I'm sure Dr. Jabin is very known in Ethiopia. We are coming out with a beautiful program for the EDPA. We are having a long-term fixed orthodontic program. You have your free WhatsApp guidance. It's a long-term program. You have your 4 days of on-site program, which is commencing on 27th July, followed by you're going to have a 65 hours of online session. We'll be doing everything as such what you're seeing right now. It is just like I'm right in front of you. So that is also credited with the 31 points. It's been awaiting a CEU point of 31 points coming in, and with the affordable program fee, which will be informed by EDPA. So if you plan to do a disciplined orthodontics, you have been doing till now orthodontics based on some YouTube or your half-cooked orthodontics, no, stop it. It is high time that we have to improve the standard of dentistry. So in case you want to improve more on orthodontics, we are coming out with a long-term program with a lot of clinical tips, lot of clinical videos, your hands-on procedure, which is all commencing on 27th July. So you can contact the authorities of EDPA. They will be guiding you better regarding that, the payment factor, which is very affordable. And at the same time, you can post your clinical cases to the group so that I can guide you. I instance, all the eminent orthodontists who are standing here will be able to guide you step by step. So I'm again going to back to my topic, that is regarding the fixed orthodontics. Is just for a small break. I mentioned you are given a high chance to improve the quality of your orthodontic practice in your clinic. Now, many a time we get confused with therapeutic extraction. Which tooth do I extract? Okay, I just mentioned about certain habits which many of the doctors are missing. I just mentioned on few of the interceptive orthodontic part which many of the patient doctors are missing. I told you, don't just look into the dentition, which extraction, is it an extraction, non-extraction, that all is okay, but you have to look into the soft tissue. Based on the soft tissue, you have to evaluate the treatment. Now, I also mentioned about your deep bite, which is 100% need to be corrected. Why? If you don't correct your deep bite, you are going to end up with iatrogenic deep bite, which is going to cause TMD. On the long run, many patients will come with joint pain, hand pain, knee pain. Everything is related with occlusion. That's something we should know. Many a time, many of the dentists I've seen is that go and see an orthopedician. 90% of the joint pains are due to poor occlusion, which many a time patients don't restore their teeth. Many a time this is iatrogenic, which by orthodontics, by doing a wrong, not a correct technique of orthodontics, sometimes if you collapse the occlusion, that also can be some of the reason for your joint pains. Now, coming into the therapeutic extraction, something very important. We are going slow by slow into clinical part. When you come across the clinical point 4, I'm going to tell. So the clinical point 1 I mentioned on look into preventive, interceptive, corrective, and surgical part. The second part which I mentioned is you have to plan for oral habit correction. The third part which I mentioned is you have to plan for interceptive part. And again, when you come into the therapeutic extraction, that is during fixed orthodontic treatment, which tooth do I extract? That's a common question by many of the doctors. How do I judge whether it is a first premolar extraction, or is it a second premolar extraction, or is it a non-extraction? In the short time, I will give you a few of the clinical cases which should 100% go for first premolar extraction, which are the few cases which should 100% go into second premolar extraction. Now, coming into your chart of extraction. This is something very important you should keep in mind when you consider the chart of extraction based on the book of Profit. If you look into the first premolar, the maximum retraction you can achieve is 5 millimeter. When you look into the second premolar extraction, the maximum retraction you can achieve is only 3 millimeters. So 5 millimeter is a maximum retraction you can achieve with first premolar extraction, and 3 mm is the maximum retraction you can achieve with the second premolar extraction. Based on that chart, there are a lot of clinical methods to assess which is a case of first premolar extraction, which is a case of second premolar extraction. So now I'm going to tell you the clinical point. What are the cases indicated for first premolar extraction, and what are the cases indicated for second premolar extraction? Do remember, first premolar, that is your 1-4, 2-4, 3-4, and 4-4 on extraction is going to give you a space of 5 millimeters for retraction. The cases indicated for first premolar extraction, if you can look into it, you can know when you have a moderate to severe crowding with or without deep bite is the first case indicated for first premolar extraction. So you have a moderate crowding or a severe crowding with or without deep bite is a case indicated for first premolar extraction. Second is whenever you have your canine overlapping your lateral incisor. Now you have your canine whenever you have your canine overlapping the lateral incisor in a convex profile, is a case indicated for first premolar extraction. So severe crowding or moderate crowding with or without deep bite, you have your crowding of canine overlapping the lateral incisor. If you see into this case, you see this patient had a convex profile. On first premolar extraction and retraction, the patient is having a straight profile. Everyone are very obsessed with the facial profile, but as an orthodontist, I will tell profile will 100% improve. What we have to check is the occlusion. At the end of the treatment, it is the duty of the dentist to provide a perfect occlusion to the patient. If you provide a proper occlusion to the patient, patient's TMJ will be at rest, will not have any problem on the long run. So don't just look into aesthetics. You also have to look into the proper occlusion at the finishing stage. Now, the third case, which is indicated for first premolar extraction, is a class 1 bimaxillary proclination. As I mentioned earlier, I'll be telling you the wire sequence. Always remember, a class 1 bimaxillary proclination will 100% go for first premolar extraction. Again, you can see or appreciate in this case a convex profile. A convex profile has been converted into a straight profile, a beautiful finish, and such also have to give a perfect occlusion with correcting the deep bite. That's another important thing which we have to consider. You can retract it, no problem. But if you're while retracting, if you're ending up in a deep bite, you're doing something terribly wrong there. So each step of orthodontics is very important. Now, the fourth case, cases which are having incompetent lips. I mentioned earlier, there are a lot of reasons for lip incompetency. So if you have an incompetent lip, potentially incompetent lip, what is a potentially incompetent lip? When you have proclined upper and lower anterior and your lips are not able to close, though the lips have sufficient lip length, but because of dental proclination, it is called as potentially incompetent lip. A case of potentially incompetent lip is again a case indicated for first premolar extraction. Again, even in this case, do remember it is your duty to provide a perfect occlusion. Why I am telling occlusion again and again? Why? Because many of the dentists collapse the occlusion at the end of the treatment. That is not again a discipline of orthodontics. Some are good in diagnosis, some are good in bonding, some are good in wire changing, but many doctors are not good in giving a perfect occlusion. Occlusion is something very important in your orthodontic practice, which you have to deliver to the patient at the end of the treatment. I will always tell, anteriors are for aesthetics, posteriors are for perfect occlusion. If you can provide a perfect occlusion by following the correct wire sequence, correct bonding, correct diagnosis, that is called as a stable orthodontic result. Now, your next is whenever the patient has a convex profile with acute nasolabial angle and deep mentolabial sulcus. Acute nasolabial angle with a deep mentolabial sulcus is again a case indicated for first premolar extraction. Again, be very careful with the occlusion. Don't disturb the occlusion. Now, you could see here, the patient gives you a beautiful smile. Why? Because they are happy with the treatment. That is our main target. You should be providing a beautiful smile with a stable occlusion such that you are sure the patient is not going to go back with any discomfort, and you are very happy that the patient got a good result with the aesthetic in the anterior and a proper occlusion at the posterior. Now, you have another lot of cases are there, which I'm in the short time, I'm not going in deep into every case, but I'll be posting all these cases with the wire sequence and the clinical tip into the group created by EDPA. So if anyone have not joined, you can enroll your name with Dr. Meron, and she'll be able to help you out to add you to the EDPA group of the orthodontic clinical tips. Now, another common case is that when you have a class 2 molar relation, some cases are there, you got a class 2 molar relation, but you have your lower anterior highly proclined and it is hitting with the palatal surface of upper anterior. That is also a case indicated with first premolar extraction. So a skeletal class 2 with the proclined lower anteriors hitting the palatal surface of upper anterior is a case indicated for first premolar extraction. Many a time, many doctors will tell, then what about the molar relation? There is no rule in orthodontics that you have to end the orthodontic result with class 1 molar. You can finish your orthodontic result either with class 1 molar or class 2 molar relation or class 3 molar relation. All these three molar relations are very stable. It is now still we have been taught in our UG curriculum only class 1 molar relation is stable. No, it is 100% is wrong. Class 1 molar relation is very stable, but along with that, class 2 and class 3 molar relation are also stable. So there is no rule that every molar relation has to be class 1. Now, another case indicator for first premolar extraction. This is the high angle case. What is a high angle case? Long face, arch length tooth material discrepancy, a narrow arch, severe crowding with the proclination. So, a case coming with a long face, with a narrow arch, dental proclination with crowding is going to be there because of arch length tooth material discrepancy. Again, the case indicated for first premolar extraction. So all these cases should be getting a beautiful result in the anterior and a beautiful occlusion at the posterior. That's our main target in orthodontics. Now, so you can appreciate the occlusion here. Occlusion should be perfect as possible. Now, coming into another case of all first premolar extraction, that is high anchorage caries. High anchorage cases, cross bites, proclination with the anterior rotation. The patients are having a highly incompetent lips. All these are highly indicated for first premolar extraction. So you have a bimax case, severe crowding with or without deep bite, mesially angulated canine overlapping the lateral incisor, convex profile with acute nasolabial angle and deep mentolabial sulcus, class 2 division 1 with proclined upper and lower anterior, high anchorage cases, your high angle cases, that is you have your vertical grower. All these are cases indicated for first premolar extraction. So you could see here, you could see the result seen in this patient from this profile. We have got into a straight profile. Patient is again happy just because we are playing with the correct mechanics and biomechanics. Now, this is a common trend in India. Like if your patient is very happy, they will tell, doctor, can I have a photo? It's our privilege to stand with the patient and take a photo. So it is common. We feel very happy from inside that the patient is requesting us, doctor, can we have a photo? Yes, we can. So this is all the examples I can show that the patient is happy with the proper result, that is with the proper occlusion and aesthetics in the anterior. Also, ectopic eruption of the canine. Ectopic eruption of the canine goes for a first premolar extraction. But many doctors, without knowing the correct mechanics, they will engage a nickel titanium wire even into ectopic eruption, and that will unnecessarily cause proclination of the upper anterior, intrusion of the posterior, and you are again going to disturb the occlusion. So, though the extraction is first premolar, you should know the correct technique of bringing the ectopic eruption or the buccally erupted canine to the arch. That is the advantage of orthodontics. By following the correct mechanics, you can do a better orthodontics. But ectopic eruption is a common case indicated for first premolar extraction. Again, these are all the beautiful results, what you are seeing after doing a beautiful orthodontics. Again, dental open bite with acute nasolabial angle. If you have a dental open bite with acute nasolabial angle, it's a case indicated for first premolar extraction. Now, coming into second premolar extraction. Second premolar, as I mentioned, maximum retraction you can achieve is only 3 millimeter. Whenever you come across an acceptable profile with the minimum crowding or minimum dental proclination in MBT system, it is a case indicated for second premolar extraction. That is 1, 5, 2, 5, 3, 5, and 4, 5. Second premolar indicated cases, the first cases, acceptable profile, minimum proclination or with minimum dental crowding. You get again a beautiful result for a second premolar extraction, but you have to be very careful with your mechanics. Now, coming into the second case, in a second premolar extraction, whenever you have a lingually rolled molar, a premolar, lingually rolled second premolar, it is highly a case indicator for second premolar extraction, because there is no point in extracting a sound first premolar and trying to bring the second premolar, which is lingually rolled, to the arch form. So a highly lingually rolled second premolar is a case indicated for second premolar extraction. Third case, this is where many of the doctors get confused. I earlier told an acute nasolabial angle dental open bite is a case indicated for first premolar extraction. Now I am telling a mild dental open bite with acceptable profile, with minimum crowding, mild dental open bite acceptable profile with minimum crowding is a case indicated for second premolar extraction. So don't get confused. If you have an acute nasolabial angle, dental open bite, good amount of dental proclination, case indicated for first premolar extraction. If you have a mild dental open bite with minimum proclination and crowding, it's a case indicated for second premolar extraction. Also, there are various other cases of second premolar extraction like grossly decayed second premolar, your impacted second premolar, or you want to have an anchor loss of 4 to 5 millimeter. All those are cases indicated for second premolar extraction. So now having a recap, I started with the preventive, interceptive, corrective orthodontics is going on. In preventive orthodontics, at least practice the habit breaking appliance for tongue thrusting and mouth breathing. When you get a case of mouth breathing, refer the patient for ENT specialist. When you get a case of tongue thrusting, look for lower lipple test. If it is positive, you have to plan for a fixed tongue grip. In a mouth breathing patient, first refer to an ENT and only then take up the case for the myofunctional appliance like an oral screen. Don't forget to practice interceptive orthodontics, correction of skeletal class 2 and skeletal class 3. I already posted regarding that video of skeletal class 2 malrelation and skeletal class 3 malrelation into the group. You have various myofunctional and orthopedic appliance which has to be practiced during the growth spurt. Then I mentioned on when you evaluate a patient, don't just look into the dentition. You have to look into the soft tissue and then also you have to look into the hard tissue. In soft tissue, I mentioned about the lips. I mentioned about the gummy smile. You can do a beautiful correction of the gummy smile with the help of orthodontic mini implant. I mentioned about the deep bite. Remember the various stages of fixed orthodontics are aligning, leveling, space closure, finishing, detailing, retention and follow. In that, many doctors don't do the leveling stage, that is leveling the caroscopy. Many doctors don't correct the deep bite, which is going to lead into TMD. What are the two types of deep bite? Skeletal and dental. In skeletal, there are three types of deep bite. I told you no visibility of lower anterior, no visibility of upper anterior, or increased overjet, lower teeth hitting the soft tissue. All these are skeletal deep bite, which has to be corrected in the interceptive orthodontic phase. Dental deep bite, long face patient, intrude the upper and lower anterior, either with the help of reverse cavity or with the help of anterior mini implant. Round face patient, you correct the dental deep bite by extruding the posterior, that is with the help of an anterior bite plate. Also, I mentioned when you plan for your first premolar extraction, what are the cases indicated for first premolar extraction? Maximum you can retract is 4 to 5 millimeter. When you have your second premolar extraction, maximum you can retract is only 3 millimeter. So you have to be very careful in your diagnosis to provide a better orthodontic care to your patients. Now, you have to be very careful with the non-extraction cases. If you ask me, do you get more relapse in extraction case or non-extraction case? I will tell non-extraction case. Why? Because many a time, if you do extraction case in the correct bonding and correct wire sequence, the stability, the bone formation, everything of the new position is more stable rather than a mild moved teeth, which is a mild moved tooth that is commonly in a non-extraction case. So remember, non-extraction cases has high chance of relapse compared to your extraction cases. So you have to be very careful in your non-extraction cases. Many doctors think that non-extraction, okay, it's very easy. I'll just do some aligning and I will finish. No, relapse is very high in the non-extraction case. You can look into the cases which you have done, especially midline dissemination cases and all. If you have not done properly, within 24 hours, it will relapse. Generalized spacing case, if you are not done correctly, within 24 hours, the space will relapse. Rotated tooth, if you're doing it as a non-extraction case, you can see within 24 hours, it will get again derotated. Why? Because derotating your midline diastema, your spacing, everything has a high tendency for relapse. So you have to be very careful when you plan for your non-extraction cases. So this is a beautiful case which I have finished with self-ligating bracket. But the clinical tip to be considered when you go for your non-extraction cases are, whenever you do a non-extraction, I'll be telling in detail into it, but do remember, whenever you do a non-extraction case, your retention should be permanent fixed lingual retainer. Do keep in mind, whenever you plan a non-extraction case, relapse tendency is very high. So every non-extraction case, it is safe to give a fixed lingual retainer. That means it is a permanent fixed lingual retainer. Now, I just mentioned regarding the stages of fixed orthodontics: aligning, leveling, retraction, finishing, detailing, retention, and follow. Now, for the doctors who are already doing orthodontics, I'm going to just mention on the correct wire sequence which you should follow. Because don't think putting a E-chain on nickel titanium wire is going to solve all the orthodontic problem. No, it is going to worsen the problem. You're not going to get a occlusion. You are not going to get a stability. Ultimately, you are going to develop a TMD. So do remember, next time when you get a case is having severe crowding, your case should start with O12 nickel titanium wire. So your round nickel titanium wire is the first aligning wire. Your second aligning wire comes with O14 nickel titanium, and your third aligning wire comes with O16 nickel titanium wire. So your O12 nickel titanium is your first aligning wire in a severe crowding case. Your O14 nickel titanium is your first aligning case in a mild crowding case. But if you don't have any crowding, still you have to start with your O16 nickel titanium wire. There are two optional wires also. Your optional wire is O18 nickel titanium wire. And sometimes if you are going through all the sequence of O12, O14 and O16 and O18 nickel titanium wire, you have to stabilize it with O18 stainless steel. So I will mention that you go for O12, O14 and O16. So minimum reach up to O16 nickel titanium wire. If your patient is allotting time, you plan even for O18 nickel titanium wire. So you should keep in mind these four wires should be there with you. You should minimum reach up to O16 nickel titanium wire. So round nickel titanium wire for a prolonged time is going to get you a perfect aligning stage. Now, you have two options in the leveling stage. Either you can, after O16 nickel titanium, you can place 1725 nitride and then you can come into 1925 nitride. So your targeted wire in leveling stages reaching up to 1925 nitride. Many doctors don't reach up to 1925 nitride in the leveling stage. That's the second stage. I will repeat to avoid confusion. You have to minimum reach up to O16 nitride in the aligning stage, O16 nickel titanium wire in the aligning stage, or much better if you can reach up to O18 nickel titanium wire. After this O16 or O18 nickel titanium wire, you have to place 1725 nickel titanium wire, followed by you have to place 1925 nitride. So remember, minimum of O16 nickel titanium in the aligning stage and minimum reach up to 1925 nickel titanium wire in the leveling stage. This is very important. I'm not going into detail of that because to express the torque, I'll be putting all this in the video. To express the torque and minimize the anchor loss, the best wire is 1925 nickel titanium in the leveling stage. But never put an elastic chain on nickel titanium wire. So O16 should be your minimum last wire in the aligning stage, and 1925 nitride is your minimum last wire in the leveling stage. Retraction, you can do either in 1925 stainless steel or in 1825 stainless steel. You have a severe proclination. I will tell better plan for 1825 stainless steel. But you don't have a severe proclination. You don't want over retraction. Best wire of retraction is 1925 stainless steel. But all these are placed only after placing 1925 nitride as the leveling wire. So your targeted leveling wire is 1925 nitride. Your targeted retraction wire can be either 1825 stainless steel or 1925 stainless steel. If you ask me, the best wire of retraction is 1925 stainless steel. But here, because of severe bimaxillary proclination, we sometimes use, instead of 1925, we sometimes use even 1825 stainless steel. After retraction, don't hesitate to finish the case. You can finish it with 1925 stainless steel. So textbook will tell 2125 stainless steel, but I will suggest minimum you should be reaching up to 1925 stainless steel as a finishing, and detailing or settling the occlusion is done in O14 stainless steel with settling elastics. So remember, if you are doing orthodontics, already you are in the field of orthodontics, you are doing good number of orthodontics. I'm sure I've been informed that many of the doctors are doing good on quality orthodontics, but do remember, along with your diagnosis and bonding, you should be very perfect with your wire sequence. In your wire sequence, I mentioned, start with a round nickel titanium wire, reach up to 016 nickel titanium wire. In the leveling stage, you reach up to 1725, but your final leveling wire has to be 1925 night. In the retraction, you are given two wires, either 1925 stainless steel or 1825 stainless steel. Best wire is 1925 stainless steel. But severe proclination cases, I sometimes use 1825 stainless steel because here we get a lot of bimaxillary proclination cases. And your finishing wire, I usually place it 1925 stainless steel. Textbooks will tell 2125, but commonly for us, I finish it in 1925 stainless steel. And if I have any occlusal problem, I want to settle or detail the occlusion with settling elastic, I usually place it on 014 stainless steel or 014 nickel titanium wire. 014 stainless is better. So remember, you should be perfect in your aligning wire, should be perfect in your leveling wire, retraction, finishing, detailing. Only then you are getting a stable orthodontic result. Now, I'm sure everyone knows regarding, I don't have to tell much on bonding. I'm not going to depth of it, but I will tell you just one word on bonding. If you're good in bonding, your result is going to be good. That's the main part of orthodontic, bonding. Why? Brackets are given all perfect program, like your tip, torque, in-out specification, anti-rotation program. Lot of programs are inbuilt into bracket. So whenever you use a straight wire, let it be self-ligating, let it be MBD system, buy quality bracket, don't buy low quality bracket, buy quality bracket, because in that quality brackets you will have proper program. These programs are going to be well expressed by the wires which I just mentioned, that is aligning wire, leveling wire, space closure, finishing and detailing wire. So I just tell you on few guidelines of initial aligning stage. The first guideline is never place a nickel titanium wire and an E-chain together. That means to say, don't place elastic chain on nickel titanium wire. Why? Because the nickel titanium wire is having the maximum friction. If you put a E-chain on a nickel titanium wire, there will be deepening of the bite. Bite will deepen because of the friction. The root will start to resorb. Third problem, you will lose occlusion. Fourth problem, you will start to get mesialization of the molar. So you put a E-chain on nickel titanium wire, you will get bite deepening, you will get root resorption, you will get a lateral open bite. That means it's called as a squeeing of the arch form, and molars also mesialize, leading to angle loss. So the first rule is don't place elastic chain on nickel titanium wire. The second rule of aligning stage, that is when you are putting an 012 nickel titanium wire or 014 or 016 nickel titanium wire, if you are having insufficient space to align, like you can see here, this lateral incisor does not have any space to align. And if you plan to engage the nickel titanium wire onto a tooth which is having insufficient space to align, the force will be dissipated to the root. It will immediately lead to root resorption and mobility. So the next rule is never engage a nickel titanium wire onto a tooth which is having insufficient space to align. If you accidentally engage thinking that nickel titanium wire is going to do everything for you without creating space, it is going to cause root resorption and at the same time it is going to cause mobility. And the third point to consider is you have a wrongly positioned bracket. If you have a wrongly positioned bracket, because all these are my own cases, I don't take any case from the internet. I will always tell you are learning from anyone, learn from a practitioner, not from an academician. I will always tell you want to learn clinical orthodontics, you have to plan for your orthodontic learning from a practitioner. So I just get you 2 minutes. Dr. Bennett, I just need to change the battery. So just 2 minutes, doctors have to hold on with it. And I will come back to the same slide again one more time. Can change the battery.
Okay, everyone. Dr. Benoy will be back with us in a few minutes. So first up, I would like to remind everyone to join the WhatsApp group. You can find the link in the chat box. So until he gets back to us, I would like to recap what we've discussed so far. So we saw that etiology is the primary and key factor we should look into before any kind of diagnosis and treatment. We should also look into mechanics and biomechanics of fixed orthodontics. So to differentiate between also the preventive, interceptive, and fixed orthodontics, we saw how to diagnose different kinds of oral habits and how to treat them. We also saw the ideal aid to treat different types of malocclusion and the different options and mechanisms. So now, since Dr. Benoy is back with us, we'll give the place to him.
Very sorry for that, because in between a small break is very essential, because orthodontics, that has solved a problem. If you oversaturate, you will forget everything. So I will keep it as low as possible. As Dr. Ben was discussing, I just mentioned on habit breaking, few of the habit breaking appliances which you should practice from tomorrow. I mentioned you should select the cases on skeletal class 2 and class 3 malformation. If you're not able to do, also not a problem, but at least diagnose and consider the special cases for specialists. You should diagnose not only dental, you should diagnose the soft tissue, that is the lips, nose, chin, cheeks, everything has to be looked into before committing the treatment plan to the patient. You should look into the intraoral, especially the deep bite, because I mentioned there are a lot of stages of fixed orthodontics. The intraoral should be checked into, especially the deep bite. I mentioned there are two types of deep bite, skeletal and dental. You have to correct the dental deep bite, long face, intrusion of upper and lower anterior during fixed orthodontic treatment, and extrusion of the molar for a round face, low angle case. I mentioned on gummy smile, you can correct the gummy smile, but for a better correction, anterior mini implant will certainly going to help you. I mentioned what are the cases which are indicated for first premolar extraction, maximum retraction is 5 millimeter, which are the cases indicated for second premolar extraction, maximum retraction possible is 3 millimeter. What are the wire sequence you should must follow? I told you O1 2 nickel titanium wire, O1 4 nickel titanium, O1 6 nickel titanium. Minimum you have to reach up to O1 6 nickel titanium, but it is even better if you can reach up to O1 8 nickel titanium wire. Your targeted leveling wire is 1925 90. It is a must wire everyone have to place. Why? I'll be telling you in detail later. It is going to express the torque. Once your torque is expressed, you will get very minimum anchor loss. The anchor loss is mainly because you are not expressing the torque which is inbuilt in the bracket. It's because of the heavy force, wrong wire, and not expressing the torque. Retraction wire has to be a rectangular stainless steel. Don't place any elastic chain on nickel titanium wire for space closure. Finishing wire is very essential. That is a stability. And if you have any occlusion problem, you should do detailing also. High chance of relapse for non-extraction cases. I will be telling you how to plan for a fixed lingual retainer. High chance of relapse. So don't think non-extraction is very easy to do. It is easy to do, but difficult to retain the result. And I mentioned, though there are a lot of stages, few of the guidelines I mentioned, not to place E-chain on nickel titanium wire. I mentioned bite deepening, lateral open bite, molar mesialization, root resorption. Everything happens if you put elastic chain on nickel titanium wire. Same way, if there is insufficient space and you are trying to engage the nickel titanium wire to bring that teeth into arch form, it is going to cause root resorption, mobility. That is the main reason that few of the cases are getting highly mobile during or after the aligning stage. That is, you are given an excess force or you have tried to pull to a tooth to an arch form where there was no sufficient space. Any improperly positioned bracket, you can see any improper is my own case. There's nothing wrong in showing the failure cases. That's what we usually tell. In the clinic, we are full-time practitioners. In the clinic, we also encounter a lot of failures. The best part is learn from the failure. That is the thing. If you are keeping on repeating this failure, there is nothing much you are doing better to yourself. That's the first thing I will tell. So I am highlighting and focusing on my own failure. Any wrongly positioned bracket, don't hesitate. Immediately debond and reposition. Many doctors are there, they will think, okay, I will do it later. Later. There is no later, because you have to do immediately. Because the ortho, the advantages, you are provided with the time. That's why I mentioned first buy the time from the patient. So you have to spend a lot of time in bonding. You have to spend a lot of time in aligning, lot of time in leveling, a good time in appliance selection, a good time in knowing the mechanics and biomechanics of ortho. So any improperly positioned bracket, don't hesitate, immediately debond, rebond a new bracket. And then only after complete aligning. What is complete aligning? When O1 6 nickel titanium wire or overnight nickel titanium wires, very passive in all the slots. This is just by visualization. If you find all the brackets are well aligned with oven 6 or overnight nickel titanium wire, that is the only time you can shift into leveling stage. So don't speed up your aligning stage. You need good amount of time for aligning. You need a good amount of time for leveling. You can forget about the angle loss in the retraction stage if you can spend time in aligning and leveling. So when we remember about the aligning stage, don't place E-chain on nickel titanium wire. Improperly positioned bracket should be repositioned. You have insufficient space to align. Don't try to engage the nickel titanium wire into that tooth. And only after proper aligning. What is proper aligning? When oven 6 or overnight nitty is passive in all the slots of the bracket, you can tell that your aligning stage is over and you can shift into your leveling stage. That is your rectangular nickel titanium wire. And our targeted leveling wire is 1925 nickel titanium wire. That's why I mentioned the leveling stage. When can you tell that your leveling stage is over? That is only when we tell that my 1925 night eye, 1925 rectangular nickel titanium wire is minimum for 5 to 6 months. That is a time required to express the torque. Once your torque is expressed, the root moves towards the cortical bone. You will get cortical anchorage and less angle loss. So in the leveling stage, do spend time to place 1925 night time for minimum of 5 to 6 months before you start your retraction stage. So don't skip your leveling stage. And that too, you should do your leveling stage with 1925 night time. And retraction, as I mentioned, you can select 1825 stainless steel or as textbooks say, 1925 stainless steel. But the retraction should be always done on rectangular stainless steel. And I've seen many doctors, they just place molar to molar E-chain. That's not a technique. Even with the correct wire, if you place molar to molar E-chain, it is still going to create angle loss. So, though because of the time, I'm not telling, but do remember your E-chain should be placed into the posted wire or to the crimpable hook, which is placed distal to lateral incisor, because the center of resistance of the 6 anterior teeth comes distal to lateral incisor. The advantage of placing E-chain from molar to the crimpable hook or E-chain from molar hook to the posted wire, the biggest advantage, since it is in line with the center of resistance, less chance for root resorption, and perfect bodily movement can be achieved if you place an E-chain from molar hook directly to the crimpable hook or from molar hook directly to the posted wire. So don't place E-chain from molar to molar. Though you may be doing on a rectangular stainless steel, you still get an anchor loss if you place molar to molar E-chain on a rectangular stainless steel. So your target should be knowing the biomechanics. Why I am going to give a E-chain from molar to the crimpable hook, which is crimped distal to lateral incisor, because the center of resistance of the 6 anterior teeth is distal to lateral incisor. So once you give anything in line with the center of resistance, the chance of bodily movement is very high. And in straight wire or even in self-ligating, what do we want? We want is a bodily movement. So remember, correct wire sequence for retraction, correct wire sequence for leveling, and correct wire sequence for aligning. But knowing all this, you should know even the biomechanics, why you should not be placing E-chain from molar to molar. It is again going to create anchor loss. So in an extraction case, be ready next time to retract using a crimpable hook or using a posted wire. Same way, as I mentioned, you have to be very stable in the finishing stage. Why? The bone formation, everything has to be perfect, which all happens in the finishing stage. So don't skip the finishing stage. Finishing stage, I usually do it in 1925 stainless steel. Finishing stage is the one which is going to get you a stable result, minimize the relapse. So if you want to minimize the angle loss, do prolong your leveling stage with a 1925 night eye. If you want to minimize the space reopening, do spend time with your finishing stage with a 1925 SS. So you have to be very careful. Follow the sequence of wires. Can be oven 2, oven 4, oven 6, maximum up to oven 8 night time. Leveling wire, your target is a 1925 night time. Retraction wire, you can either retract in 1825 severe proclination cases, or you don't want over retraction. The best wire of retraction is 1925 stainless steel. Finishing 1925 stainless steel. If you have any occlusal problem, detailing wire. All this should be followed based on the guideline. Now, This is something very important. I told you, your non-extraction cases has high chance of relapse. So next time, when you come across these type of cases, generalized spacing, midline diastema, anterior rotation more than 30 degree, adult patients, periodontically compromised patients, tongue thrusting patients, you have to give fixed lingual retainer. So do remember, fixed lingual retainer in the upper and lower arch is very essential for cases of midline diastema, generalized spacing, that is non-extraction cases I'm telling, anterior rotation more than 30 degree, periodontally compromised patients, adult patients, tongue thrusting patients, retreatment cases, which is very essential. All retreatment cases should be given a fixed lingual retainer. All these type of patients coming, do remember your appliance selection, diagnosis, mechanics, biomechanics, and retention should be perfect. Now, again, if you ask me, do I do MBT or self-ligating more? If you ask me, I prefer self-ligating better because there are a lot of advantages with self-ligating, especially diamond system. You have less friction, you have less wire sequence, less chair side time, less appointment, more hygienic, less plaque and bacteria accumulation. So to the next step, if you have not started with self-ligating, it is high time that you have to start with your self-ligating system. So if you know the MBT, that is a basic fixed orthodontic treatment, it's easy for you to step into your self-ligating system. Once you know the mechanics and biomechanics, I will always suggest on the long run, no, I am a Invisalign provider, I am a certified Invisalign provider. On the long run, we should also learn in depth into the mechanics and biomechanics of clear aligner. It is very essential. Why? Many of the patients are now asking and demanding for clear aligner. Don't just do clear aligner based on a company. So company will tell do interproximal stripping there. Don't do like that. You have all the right to ask the designer or the treatment plan provided by the orthodontist what are the options available for clear aligner. So next time, if you are planning for a clear aligner, check into the ClinCheck properly. Look into what are the treatment options. Clear aligner can even give you a better expansion. You have to plan for clear aligner only after checking into the virtual setup which is given by the company. So orthodontics is fast developing. You have your MBT system, regular metal bracket system. You have your self-ligating diamond system, and a lot of other systems are available. Very hygienic, less chair side time, less wire sequence, speedy treatment. Everything happens with self-ligating. Also, the technology is improving now. So now presently, we are slow by slow stepping into the clear aligner technique. We are doing a lot of clear aligners here with our local companies are there, Invisaligns are there, everything. They are doing wonders now with the clear aligners. So you should be planning even for a clear aligner. There's a few of the cases which I finished with clear aligner. So now looking into what I just mentioned again for the last recap, if you ask me, first look into the etiology of every case. Whichever case is coming, don't just hurry with your case. Take your time, look into the etiology, what caused the problem. Find out the etiology. Inform the patient and the parent. Next is selecting the correct appliance. It can be a regular MBT system, it can be a self-ligating, it can be a clear aligner. But select all these appliances knowing the mechanics and biomechanics. If you are doing any of these appliances, especially the fixed orthodontic, you should know the correct wire sequence. What are the aligning wires? What are the leveling wires? What are the retraction wire? Why I should use a crimpable or a posted wire during retraction? Based on the biomechanics, you're going to get a crimpable or a posted wire, you're going to get a perfect bodily movement. That is translation movement. Which are the cases indicated for fixed lingual retainer, non-extraction, generalized spacing, midline diastema, anterior rotation more than 30 degree, adult cases, periodontally weak patients, your tongue thrusting patients, retreatment cases, everything require fixed lingual retainer. Also, you should check into the skeletal class 2 and class 3 mal relation, which should be practiced during interceptive orthodontics. You should check from the younger age, preventive orthodontic part, your space maintainer. You should look into your oral habits, especially your tongue thrusting, mouth breathing. Everything has to be checked because you are bound to give a proper treatment, especially orthodontic treatment is the best thing you can give it to your patient at the younger age. You also should check into the soft tissue, lips, gummy smile. Why your gummy smile can be corrected with the anterior minimum line. Better intrusion. How much intrusion possible? For 1 mm intrusion, how much gummy smile can you reduce? Don't forget the stages of aligning, leveling, space closure, finishing, detailing. Why I again stress on leveling? Many doctors don't correct the leveling. That is, the deep bites is not corrected. You have to level the curvoscopy. What are the different types of deep bite? I mentioned skeletal or dental. What are the two types of dental? True or pseudo? How to correct the pseudo dental deep bite? Intrusion of upper and lower anterior. Long face patients, don't extrude the molar. Intrude the upper and lower anterior. Round face, low angle cases, extrude the molar with the help of anterior bite plate. At the younger age, correct the deep bite. Then, when we come across extraction, which all are the cases indicated for first premolar extraction? Which are the cases indicated for second premolar extraction? Why non-extraction should be given fixed lingual retainer? Because they have high chance of relapse. Wire sequence to be followed in aligning, leveling, space closure, finishing, detailing. What are the guidelines of aligning? No ECA, non-nickel titanium wire. High friction. There is high chance of mobility. Insufficient space. Don't try to engage the nickel titanium into that tooth. High chance of root resorption. Any improperly positioned bracket, reposition at the earliest. Your aligning should be perfect. How to know my aligning is perfect? Visualize that your O16 night eye or your O18 night eye should be passive. When is your leveling stage over? When 1925 night eye is there for a minimum of 5 to 6 months. Why prolonged 1925? It is going to express the torque. The root is going to move towards the cortical bone. Better cortical anchorage, less angle loss. Retraction only in rectangular stainless steel. Don't place any chain on rectangular nitty also. Nickel titanium. You have to place it on rectangular stainless steel. Finishing wire for stability. In case you have detailing occlusal problem, don't hesitate to put settling elastic in on for nickel titanium or on for stainless steel. Be very careful with your retention part. So when you plan your orthodontics, you have to be proper going for a proper diagnosis and treatment. That is the first thing keep in mind. Spend time with the patient. Do good to the patient. Aesthetics, anterior, occlusion, posterior. Should I do preventive? Should I do interceptive? Should I do corrective? Should I do surgical? These are the common questions. At what age should I do preventive? What age I should do interceptive? When to start my fixed orthodontic treatment? Everything should be very well known to you before you enter into the fixed orthodontic part. Correct bracket system enabled. You can do either an MBT system or a self-ligating or a clear aligner, no problem. But the case should be correct for your fixed orthodontic and the case should be correct for your clear aligner. Most important thing is the third point. You should know where to position the bracket because the programs in the bracket like tip, torque, in-out specification, anti-rotation program, everything is going to be well expressed by the wire only if you position the bracket at the correct spot. Arch form. I'll be posting tomorrow regarding this, the arch form video. So you can have an in-depth knowledge into arch form and aligning. I'm not going into depth of aligning, but at least remember the guideline. Why not to place each chain on night eye? Why you should not be trying to engage a tooth which is crowded? Why you should reposition the bracket? What are the wires of aligning should be very well kept in mind. Leveling is the most important stage. I mentioned 1925 night eye is a must. And then correction of class 2 and class 3 discrepancy. I mentioned skeletal class 2 and class 3 should be corrected in the interceptive phase. Don't delay it. Because if you delay it, you think that the patient is going to ready for surgery, chances are very less. Then your only option is you have to compromise the case. That's called as camouflage. That means because you didn't correct the skeletal problem, the patient have to suffer lifelong with that compromised result with fixed orthodontic. That should not happen. And then space closure, that is very important. Your elastic chain, why you should be going to a crimper block, why you should go into a posted wire, which chain to be used. That's also something very important to keep in mind. But all the time, remember, space closure should happen on a rectangular stainless steel. Why a proper finishing is required in 1925 SS? Because it needs stability. And what is the correct retention protocol? Even though you don't remember regarding retention, at least remember midline diastema, spacing, adult cases, periodontally weak patient, retreatment cases, tongue thrusting patient. All this should go for fixed lingual retainer. So considering all this, if you ask me, since from the EDPA they have asked, the authorities have mentioned a lot of doubts are there. So what I will tell is that I will take up the doubts in few minutes from now. I've been very recently to the beautiful country of Ethiopia. Myself, Dr. Jabin were there. Dr. Satyun was there. Dr. Yaya, Reddit, Dr. Nati. Lot of doctors were there. Happy enough, but that was a short-term program. It was just for an introduction part. Lot of doctors joined. We're very happy with that. We have a lot of hands-on coming in. So this was one group I very recently met in Ethiopia. You can see the happy faces there. At the same time, as I mentioned earlier, we are having our long-term fixed orthodontic program, hands-on, with the 4 hours, 4 days of on-site and 65 hours of online program coming in for knowing the basics of orthodontics. This could be commonly attended by the beginners, also for the doctors who are already doing fixed ortho and you want to improve on the standard of orthodontics. That's what I mentioned is that orthodontics as a discipline. Don't just do orthodontics vague by knowing some night, some chain, some root option, some angle loss. No, that is not orthodontics. You are doing something good to your patient. If it is with orthodontics, you have to do it with proper bonding, proper wire sequence, knowing the mechanics, and most important, biomechanics. Above all, you should know how to select a case. And we are providing you the guidelines for each clinical cases. We'll be continuing with the clinical tip WhatsApp group. So anyone who want to join regarding this program on which is commencing on 27th, you can contact EDPA. They will give you a lot of information regarding this program. So here, Dr. Yaya, Dr. Satyun, at the same time, we'll be also like when we come across, this can be even blended if required. I'm not telling that you have to do, but the program can be blended with a MS Orthodontic Award. That's a European degree from Unipegaso University. So many doctors have joined for this MS Orthodontic program. But if you feel, no, I don't want to get a MS orthodontic program from the European university, you can certainly, if you wish to incorporate the basics of ortho, doing only the clinical cases, and you're telling, no, I just don't want to do an MS orthodontics, I just want to learn orthodontics from or from the eminent faculties, what you see here, you can join for this regular long-term fixed orthodontic program, which is at an affordable price, which is given to the EDPA members. But at the same time, later, if you feel that you want to upgrade yourself, knowing more from the European university, there are a lot of eminent faculties. What you see here, you have a lot of French who's coming to teach you, and you have a lot of doctors, even from Kenya. We have a group of orthodontists who are coming to teach you more on MS orthodontics. You can later, I'm not telling now, later can even join for this MS program, which is a blended program with the program which we are going to do it with EDPA. And at the same time, very recently, just few months back, this was my crowd. I'm the smallest one seated here. I had a very big program in Sri Lanka, and many of the doctors have informed me after my session. Many of the doctors here are doing orthodontics, but they have informed me after my session they were able to improve at least one step. Maybe in the short webinar we are not able to highlight on all the steps, though we are going to highlight on all the steps on correct hands-on, everything with the videos of the patient, everything in our program, which is going to commence on 27th of July. But still, why I'm very happy with the Sri Lankan doctors are that, because there's a bunch of doctors who have come for my webinar. At the same time, then after webinar, they called me directly to their country to provide a on-site program. You can see a lot of doctors. I'm the smallest one seated here. So what I felt happy is that many of the doctors came and told, doctor, we had a lot of advantage. We were able to provide at least 1% better than what we were doing yesterday just by attending a one day program. But many of the doctors later joined for the long-term program because they understood the value of orthodontics after listening to the main faculties. So we have a lot of faculties which are coming in to Ethiopia on 27th of July this year. And I have personally have I'm only one of the faculty to the MS Orthodontic program, and there are a lot of other faculties which will be coming to you later on. And I also have my orthodontic long-term program, which we are planning to have it in collaboration with the EDPA. I have the same program which has been conducted in India, Dubai, Thailand, Philippines, Sri Lanka. Though I am a full-time practitioner, I find some days, like since we have a lot of faculties coming in, I find some days, maybe on a Saturday or a Sunday, maybe once in 2 or 3 months, we come out to teach, because it's something which you are knowing a lot of things, and it is your planning, you are feeling happy to share your knowledge with the other people. It's something, it's by God's grace, we will tell, because that's a blessing given for many of the doctors. They know something and they are sharing with the other people. Maybe you are not going to see, or maybe you are going to see me for a long time. But that's a blessing, what we will tell from God's side. So we have our program happening in India, Dubai, Thailand, Philippines, and Sri Lanka. Next, our program is coming in Ethiopia. I'm not the only faculty. There are a lot of other faculty. I'm the smallest one of the faculty out there. So there are a lot of other faculties which are going to join for this program. They will highlight you much better. At the same time, I should take the privilege. I don't have to inform or mention you about Dr. Jabin. We are also having, with the dental experts, we are having a very good implant program, which is also commencing on July 29th. That is again, our ortho program is starting on July 27th, but this is a comprehensive implant program for the beginners headed by Dr. Jabin. I'm sure I don't have to inform you who's Dr. Jabin because he is part of EDP. I'm sure Dr. Maroon and everyone over there are well versed with Dr. Jabin, and he has a bunch of specialists who are going to come for training into implants. That's a group of doctors. There, prosthodontists are there, oral surgeons are there, radiologists are there. This is also a GCI accredited program. That's a program. So that's an advantage with the hands-on model and on patients. And the credit points are also allotted. So you have an option now. You have your option to upgrade yourself in dentistry. I'm not telling only orthodontics. You have a chance of upgrading yourself in dentistry. You can upgrade yourself in orthodontics. You can upgrade yourselves in implant, which is commencing again on July 29th, headed by Dr. Jabin. So EDPA is going to inform you regularly regarding this program because the effort taken by EDPA is to bring a better teaching faculties and provide a better dentistry to the Ethiopian patient. So if you're willing, you can inform EDPA regarding your interest to join orthodontics. At the same time, your implant programs are also starting. The EDPA will inform you regarding it. So this is also a highly recommended program. If you're planning to join for implant, I will tell rather than going into any other country, this comprehensive program is going to happen in Ethiopia. So it's a greater advantage for you because I am working here in Kerala. I've seen a lot of doctors from Ethiopia travel to India to learn from Dr. Jabin. But this is a bigger advantage for you. He's traveling there to Ethiopia to teach also. That's a bigger advantage which you can take it from Dr. Jabin. At the same time, if you want to upgrade yourself in ortho, we are having our program, as I mentioned, on July 27th. You can inform EDPA regarding. So what I will tell is that before I take up the questions, I know many of the doctors are ready for the questions. Before I take up with the questions, let me inform, don't hesitate to practice preventive and interceptive orthodontics. If you are doing corrective orthodontics, do the corrective wire sequence, do the corrective bonding. If you follow the correct sequence, don't forget to follow the correct protocol for your retention. And don't forget, remember about the oral habits, remember about the myofunctional, remember about the interceptive orthodontics. Remember how to go for a proper diagnosis of the soft tissue. Remember what is the deep bite, what are the different types of deep bite. Also, cases indicated for first premolar extraction, cases indicated for second premolar extraction, guidelines of each stages of fixed orthodontics, like your aligning, leveling, space closure, finishing, and detailing. And as I mentioned, we have a lot of cases. All these cases will be posted to the clinical tip group. So later, if you want, you can inform the authorities of EDP. If you want to join with the clinical tip orthodontic group, you can inform Dr. Meron or the authorities related with it. You can join with the clinical tip WhatsApp group. The advantage is that every day you're going to get a lot of clinical tips. One will be with a video and the other will be with the clinical cases. I'll be posting my own clinical cases with the treatment chart. So if you are joining with the program also, you can inform your EDPA, which is commencing on July 27th, or you are not joining, but you want to upgrade yourself in orthodontics, but that will be for a limited time. I will always suggest if you don't want to join, okay, you can at least upgrade on the part of orthodontics by joining with the clinical tip WhatsApp group. But I will certainly suggest if you are doing just by seeing the YouTube or from others' view, that is not going to give you a long-term benefit by doing a good orthodontic. You want to do good orthodontics, learn from a good practitioner, and do better for the orthodontic patients in Ethiopia. So thank you. I will go back to Dr. Bennett regarding any doubts are there. I will take up, I hope if the chat box is there, I can take up from the chat box. So, Dr. Bennett, can I start with the doubt clarification? Because here in India, it is already 11:45 in the night, and tomorrow I have a big group of session happening in India from morning 8 o'clock. So I think I directly go for the doubt clarification. See, yeah, okay. May I just read about this? Elaborate again on tongue thrusting habit evaluation, please. Okay. Now, a patient who's coming to you with, they are not going to come and tell that I have a dental, I'm having a tongue thrusting problem. They're going to tell, I have a dental pain or I have a teeth which is mobile. It is the duty of the dentist to check whether there is a dental oral habit present. Many a time you may have proclination, you may have spacing, you may have narrow arch, you may sometimes even have an open bite. Suspect tongue thrusting. In tongue thrusting, you get to know the tongue is going to thrust between the upper and the lower teeth. So the best method to know is that by lower lip pull test. When you pull the lower lip of the patient and the patient is trying to strain the upper lip to get the lip seal, or the patient is trying to pull the lower lip to elevate to touch with the upper lip, or when you pull the lower lip and you are still seeing the patient is keeping on thrusting the tongue, it's a high indication the patient is having tongue thrusting. So in those type of patients, you should inform the patient and the parent you are having this oral habit which need to be treated before the age of 10. Ideal age is between 6 to 10, and the fixed tongue grip should be there for a minimum of 9 months. How do you know your open bite should come into a deep bite or minimum of 2 mm bite? So, tongue thrusting, the other name of tongue thrusting is retained infantile swallow. So, if your infantile swallow is retained even after the eruption of the first permanent molar, that is the time we will tell the patient is having tongue thrusting. So, the other name of tongue thrusting is retained infantile swallow. So I hope that clears the doubt of the tongue thrusting. Uh, yeah. Do we need a gingivectomy as a treatment of gummy smile? After, yes, 100%. That is a very good question. It is asked, do we need gingivectomy in the treatment of gummy smile after mini implant intrusion? Which size mini implant you mostly use for anterior intrusion? So that's a two-part question. One is, do you need a gingivectomy after anterior intrusion with the help of orthodontic mini implant? And what size mini implant do I use? I'll be posting that video within a week, but I will tell you directly to the answer. I usually use 1.6 into 8 millimeter orthodontic mini implant distal to lateral incisor for anterior intrusion. 1.6 into 8 millimeter orthodontic mini implant distal to lateral incisor, that is between canine and lateral for anterior intrusion. The biggest problem to keep in the clinical tip to keep in mind is that many doctors keep on changing the e-chain for anterior intrusion on 30 days basis. Never change the e-chain for anterior intrusion in 30 days. Minimum maintain the e-chain for 60 days for anterior intrusion, because you need the least force of only 30 to 40 grams for anterior intrusion. So if you give an excessive force, it will cause exostosis. That is, a bone formation happens around the root. And another problem is that in case your clinical crown height is reducing after orthodontic mini implant intrusion, it is advantage if you do a gingivectomy. So the answer is, if your clinical crown height is very less after your mini implant intrusion, you can do gingivectomy. The second answer was, what is the size of mini implant I use? I use 1.6 into 8 millimeter is the anterior mini implant intrusion, which is placed between lateral and canine. So can we do only upper jaw braces for class 2 patient? No. Whenever you do a braces, it is safe except for midline diastema case, or maybe the patient is coming and telling that I have a very small midline diastema. Okay, from the clinical side, I tell, because I am a clinician, I will tell, okay, acceptable to do a upper fixed orthodontic. The question was, can we do only upper jaw braces for class 2 patient? No. Class 2 patient should be always starting braces both on upper and lower arch, because there is an elastic called as class 2 elastic, which is placed from lower molar to upper canine. So if you want to place a class 2 elastic, that is an elastic from lower molar to upper canine, the braces should be there in the lower arch. And it's a discipline of orthodontics. Whenever you are doing braces for a proper occlusion, it is better to have your braces both in upper and lower arch. Could you please elaborate about engaging teeth on crowding cases using nickel titanium wire? That's what I mentioned. Don't engage nickel titanium wire onto a teeth which is having insufficient space to align. If you're having insufficient space to align and you engage that teeth, engage that nickel titanium wire onto that teeth, it will not have that space to come outside, and naturally it will cause root resorption and mobility. So there are various techniques to distalize the canine, either with a lace back, which is called as an active lace back, and a lot of other options are available. Only after creating space, you are supposed to engage the tooth, which is labially placed or lingually placed, into the nickel titanium wire. So don't engage nickel titanium wire onto a tooth which is having insufficient space to align. It is only going to cause mobility and root resorption. So that was a question. Could you please elaborate about engaging teeth on crowding cases using nickel titanium wire? So only after creating space, you can engage the wire, you can engage the teeth to the nickel titanium wire. So what is your recommendation on a long face patient with severe open bite? Thank you. Okay. Recommendation, that is a very good question. It was asked by a very good doctor. What is your recommendation on long face patient with severe open bite? That's a very beautiful question. I'll tell you, that doctor knows orthodontics, because his question was, the patient is having a long face and the patient is having an open bite. You cannot extrude your anteriors. Whenever, remember, you have a long face with open bite, long face with open bite, your target to close the open bite is not by anterior extrusion. Your target should be by intruding the posteriors. So when you have a long face open bite, you intrude the anterior, you intrude the posteriors. How to intrude the posterior? You can do intrusion of posteriors only with the help of orthodontic mini implant. Mini implant is placed on the palatal aspect as well as the buccal aspect, so that intrusion of the upper posteriors happen. What happens when your upper posteriors intrude? There is anti-clockwise rotation of the mandible. So naturally, your open bite is closing by anti-clockwise rotation of the mandible. So if you have a long face with an open bite, your target should be intruding the posterior with the help of orthodontic mini implant. Once your intrusion of posteriors happen, your mandible will rotate anti-clockwise direction, and that is going to deepen the bite, and that is going to reduce the vertical dimension. Reducing the vertical dimension is the best method of correcting your open bite. Commonly, we'll tell, if you have a deep bite, you are extruding the molar. That means you are rotating the mandible in a clockwise direction. So extrusion of molar, anti-clockwise rotation is going to open the bite, and anti-clockwise rotation of the mandible is going to deepen the bite. So molar intrusion with the help of buccal as well as palatal mini implant is the easiest technique to correct a severe open bite with long face, or a high angle case with an open bite is corrected with posterior intrusion. Especially the upper molars are intruded with the help of orthodontic mini implant, which is placed on the palatal as well as the buccal. I'll be posting my cases regarding that. So any other questions are there? You can post me. I will be happy enough to, yeah. So could you elaborate about engaging teeth on crowd? That's the same thing I mentioned. Please don't engage any teeth which are not having space to align with a nickel titanium. Your target is going to create space with active lace back, or there are a lot of other techniques of creating space by engaging, without engaging, only after creating space, you engage the teeth with the help of nickel titanium. When you have a severe crowding case, the one clinical tip I can tell you right now is start with O12 nickel titanium wire, because that's a very lengthy answer which I have to actually give on how to create space on crowded teeth. But time being, remember, active laceback is one technique, and use smaller dimension wire, that is an O12 nickel titanium. And the third clinical point is, whenever there is an insufficient space, don't try to engage the nite onto that tooth. That is only going to create mobility and your root resorption. Just uplift, maximum. Go. Okay, what is your consultation for 9-year-old boy with a skeletal deep bite with a retrognathic and small mandible or anterior? Okay, 9-year boy. Actually, for boys, the growth spurt is between 14 to 16 years. Growth spurt is between 14 to 16 years. We will tell facial hair on the upper lip, facial hair on the chin, your muscle mass. All these are the secondary sexual characters for a boy. For a girl, we will tell that there is a fat deposition at the hip, menstrual cycle will start. All these are the indication that is the girl is at the peak velocity of growth. But now, since the question is asked for a boy of 9 years, I will tell, if there is a skeletal deep bite, you cannot correct a skeletal deep bite with the help of anterior bite plane. You have to check whether the skeletal deep bite is due to vertical maxillary excess. If the deep bite is due to vertical maxillary excess, as I mentioned, gummy smile, you can correct that deep bite with headgear face bow assembly. So I posted the video regarding that yesterday. If you have a skeletal deep bite due to vertical maxillary excess, you can correct that with the help of headgear interceptive orthodontics. If you have a skeletal deep bite due to retrognathic mandible, you will be delaying that case because the patient's growth spurt is, as I mentioned, starting at 14 or 16. You have to at least delay the case until the patient is 14 or 13 years. If it is a skeletal deep bite due to retrognathic mandible, you have to advance the mandible with the help of a myofunctional, that is like a twin block or herps. So, skeletal deep bite due to vertical maxillary excess, orthopedic appliance, headgear. If you have skeletal deep bite due to retrognathic mandible, myofunctional during the growth spurt, that is between the age of 14 or 16 or maximum by the age of even 13, not a problem. So, if the question is 9-year boy, skeletal deep bite, retrognathic, small mandible. You cannot correct a small mandible. Keep in mind, with the myofunctional appliance, you can only correct a retrognathic mandible. That is, your muscles are activated to bring the normal sized mandible to the forward position. But a small mandible cannot be corrected with a myofunctional appliance. So, you have to understand, retrognathic mandible only can be advanced with a myofunctional appliance, but a small mandible, that is, we'll tell it's a micrognathic, cannot be corrected with a myofunctional appliance. And upper anterior crowding, it depends. Upper anterior crowding, if there is a cross bite at the posterior, or if the posteriors are having a narrow arch, I will usually suggest that better to go for an expansion appliance. You should know whether the deep bite is skeletal, whether the cross bite is skeletal or dental. That's the first thing to keep in mind. If your posterior cross bite is with a narrow arch, we'll consider the arch is narrow and the teeth is buccally placed. Narrow arch with the teeth buccally placed, but still there is a posterior cross bite. That is a skeletal cross bite which need a skeletal expansion. If you have a broad arch with a palatally tipped posterior, that is a dental posterior crossbite which can be corrected with a slow maxillary expansion appliance like a Cordelix. I repeat, narrow arch, buccally tilted posteriors which are in crossbite do rapid maxillary expansion. You have a broad arch with an upright posterior teeth, but still in crossbite, that is a dental crossbite, which has to be corrected with either a jack screw or even with a Cordelix. So, anterior crowding, narrow arch, expansion is the best protocol at the younger age. So, what do you say about patient present with a history of trauma? Now have ankylosed canine. Okay. Now, what doctor mentioned is ankylosed canine. You cannot move an ankylosed teeth. Why? Because for orthodontics, we are not concerned with endodontics. Endodontics is done inside. orthodontics is related with periodontium. So if you don't have a periodontial ligament, that is an ankylosed teeth does not have a periodontial ligament, you cannot move an ankylosed teeth. It is just like an implant. You cannot move an implant with fixed orthodontics. So to move an orthodontic, to get an orthodontic treatment or tooth movement, you certainly need a periodontial ligament. Ankylosed teeth will not have periodontial ligament. So you cannot move an ankylosed teeth. At the same time, doctor also asked also about the root canal treated tooth. That's why I just mentioned root canal treated tooth is not a contraindication for fixed orthodontic. We are not related with endodontics. We are only related with periodontium. So if the root canal treated tooth is having lamina dura or a good periodontial ligament around the periodontium of the teeth, you can do orthodontic treatment on a root canal treated teeth. No problem. You can easily move a root canal treated teeth because we are related with periodontium, not with endodontics. But you cannot move an ankylosed teeth because it is not having a periodontial ligament. Could you please explain cause of lingual inclination of molars? Yeah, that's a good question. The doctor asked, could you please explain cause for lingual inclination of molar on buccal tube? Two reasons. I will explain to you. Actually, all these slides are there, but since because of the lack of time, I will tell. Two reasons are going to cause rolling of the lower molar. One, wrong arch form of the wire. That means if your arch form of the wire is narrow, it is going to create lingual rolling of the molar. But above that, there is another reason. If you bond your premolar bracket and your bondable buccal tube too much cervical, that means too much gingival, the torque expressed by the wire is more. So if you have a negative torque, what will happen? The root is going to move more towards the cortical bone. If the roots are moving more towards the cortical bone, naturally the crown will tip lingually. So two answer. One is wrong selection of the arch form. Second is doctors bonding the lower premolar brackets as well as the buccal tube too much gingival. Bonding the bracket too much gingival is going to express additional negative torque. When negative torque is additionally expressed, the root is going to move more towards the cortical bone. Once the root moves more towards the cortical bone, there is a lingual rolling of the lower molar. So lower molar rolling happens due to wrong arch form and bonding the brackets too much gingival. So that's the main reason doctor is going to get lot of lingual rolling of the lower molars. Now, can fixed lingual retainer be used in conjunction with clear retainer simultaneously? What happens if used like so? The patient can. Okay, to be very frank, I usually give all the non-extraction cases fixed lingual retainer. Along with the fixed lingual retainer, I also give a clear retainer. So I just don't only give a clear fixed lingual retainer. Along with the fixed lingual retainer, I also give a clear retainer because if, in case the patient fracture, even I also get failures with fixed lingual retainer. There's nothing wrong in telling about the failure. In case the fixed lingual retainer fracture, there is high chance of relapse within 24 hours. But in case the patient is also having a clear retainer, the advantage is that we are not going to get any relapse and we can tell the patient to report at the earliest to refix the fixed lingual retainer. So I usually give fixed lingual retainer and clear retainers together. How long does one wire has to last during aligning stage before? Okay, that's a good question. For me, doctor have asked how long the wire has to stay in the aligning stage. For me, I will always tell, let me tell first with my final aligning wire is 016 nickel titanium wire. For 016 nickel titanium or 018 nickel titanium, what I see is that my wire should be passive in all the slots of the bracket. That means to say there is no time. Once my wire is passive in all the slots of the wire, that means no bend. That is the time I will tell my aligning stage is over. So 016, I will tell I don't have any time. Until it is passive, 016 and 018 nitty is there. And then only I will shift into rectangular nitty. But if my first wire is 012 nickel titanium, the minimum time I place 012 nickel titanium wire is minimum of 3 months. So minimum, I'm telling is minimum. Maximum can be any time. So minimum, your initial wire should be there for 2 to 3 months. That is a must. Maximum can be any time. The rule is if I'm engaging oven to nickel titanium wire, when visually I can analyze that my oven 4 can easily pass through, that is the time I am supposed to shift to oven 4 nitty. But as an answer, I will always tell minimum time is 2 to 3 months. Your aligning wire, first wire should be there in the patient's mouth minimum for 2 to 3 months. And in oven 6 nitty, there is no time. Until your oven 6 or oven 9 nickel titanium is passive, the wire is going to be there. On which stage and on which wire do we use a class 2 elastic? As I mentioned, all the elastics should be used on stainless steel wire. So commonly, I give class 2 and class 3 elastics on rectangular stainless steel wire. Rectangular stainless steel wire is commonly used in the retraction stage. That's why I told about the guideline. Don't use any elastics on nickel titanium wire. Your aligning stage is having nickel titanium wire. Your leveling stage is also having nickel titanium wire. But all these rules have changed with self-ligating bracket. In self-ligating bracket, I even give the elastics on 1425 copper nitty and 1825 copper nitty. So I'm not confusing now at this last moment. Basically in MBT, don't give elastics on nickel titanium wire. You give the elastics on rectangular stainless steel wire. That is in the retraction stage. But in self-ligating, I will usually give the elastic class 2 and class 3 elastics even on 1425 copper nitty as well as on 1825 copper nitty. So in self-ligating, I give the elastic on nickel titanium wire. But in MBT, I don't give the elastics on any nickel titanium wire. I give it only on stainless steel wire. So how to manage upper arch constriction that lead to crossbite? Again, the same thing. Why all these are going into crossbite is because I mentioned the wrong selection of the arch form and bonding the bracket. Too much gingival is going to provide additional additional buccal torque. Once your buccal torque happens in the upper, your palatal movement of the crown happens. So if your bonding is wrong, posterior crossbite chance is very high. For therapeutic extraction case, at what stage is extraction? That's again a good question. For therapeutic extraction, what stage do you recommend extraction? I will tell from my side, for me, because I'm a practitioner, I will tell, if you have no crowding, if I don't have any crowding, and that's a case indicated for extraction, I usually delay my extraction for 2 to 3 months. Why? Extraction becomes more easy. But if that is a case with crowding and require extraction, I usually do the extraction early. Why? Because if I don't have any sufficient space to align the teeth and I engage the nite onto any of the teeth, that is going to cause root resorption. So in a crowded case, I will do the extraction and only then I will place the wire. In a case where extraction is indicated but there is no crowding, I will delay my extraction for a minimum of 3 to 4 months. So can fixed retain be, that I have already mentioned. In case of severe crowding with the difficulty in nite alliance, can we do? Yes, that's one thing. In case of severe crowded teeth with difficulty in engaging nite during the aligning stage, can we do extraction? Yes, that's why I mentioned whenever there is crowding, better do the extraction and then only engage the nite. A case which is indicated for extraction, but there is no crowding. If you want, you can delay the extraction for maybe 3 or 4 months. I usually delay for 3 or 4 months because extraction becomes more easy. Can we use power chains on nickel titanium? No. The answer is no. I told you there will be bite deepening, skewing of the arch form, root resorption, molar mesialization, distortion of the arch form. So don't place E-chain on nickel titanium wire. What other things do we consider during the finishing? In the finishing stage, if your bonding and your wire sequence is correct, we don't have to do anything because it is in the finishing stage that you are planning to go for expression of the final programs of the bracket, that your tip, torque, in-out specification, anti-rotation program, everything. Along with that, you also have to plan for cosmetic detailing. So if you want to minimize your work in the finishing stage, be very good in bonding, be very good in changing the wire, be very good in following each steps of fixed orthodontics and arch form selection. If these four accessories are correct, you don't have to worry about anything regarding the finishing stage. So finishing stage is the depending upon the quality of the bracket which you have bonded. If you have bonded a quality bracket, you're going to get a good finish. If you have bonded a low quality bracket, your expectation of the finishing stage also will be poor. So what do we do in the Consolidation phase. Consolidation phase. I don't know. I think it's a finishing stage, which I just mentioned. So just move up. Just move up. Okay. So I should be. If any doubts are there, as I mentioned, anything which I missed out, I'll be posting. So again, the same question: can fixed retainer be used in conjugation with the clear retainer on the same arch? Yes, that's what I mentioned. I give fixed lingual retainer and clear aligner, because for me, as I mentioned, what will happen if you use it like so? Careless inducing debonding happens again. That's what I mentioned. See, you can give a fixed lingual retainer along with your clear retainer. Nothing wrong. As doctor correctly mentioned, you can get small amount of debonding even with fixed lingual retainer. Even I also get. So the advantage of clear retainer is, the biggest advantage is, even though your fixed lingual retainer fracture, the clear retainer is not going to allow any relapse. We usually tell the patient, in case your fixed lingual retainer fracture, do return within 24 hours, because in orthodontic treatment, your relapse can happen within 24 hours. So I give fixed lingual retainer along with the, I will also give a clear retainer. So how long does a fixed orthodontic treatment take an average? That's a big question. How long will a fixed orthodontic treatment happen? That we cannot predict actually. It depends upon the bone density. It depends upon the patient cooperation. It depends upon how the patient is taking care of the braces. For me, I usually tell all my patients, if it's a simple case or if it's a difficult case, I will tell only the minimum time. I will not tell the maximum time. I usually buy the patient 2.5 years to do a basic ortho case, because you need time. That's why I told in the beginning of the class, you first buy the time from the patient. If you get time from the patient, your orthodontic result is going to be stable. Second, do only the cases which are in your hand. Like if it's a simple case, you do it. If it's a special case, don't hesitate to give it to the specialist. That's why the specialists are there. So the main part of success of orthodontics is doing what is bound to do and doing what is a specialist. The special cases should go to the specialist. That's the first thing. Not only ortho. Let it be endodontics, periodontics, endodontics, anything. Special cases should be dealt with a specialist. That's why they are having the additional degree. So remember, from the patient side, if it is a difficult case and that demands specialist attention, don't hesitate. You tell the patient, this is a special case. I'm going to call a specialist for you, or I'm going to refer to you as specialist. Nothing wrong. You didn't miss the patient, but you actually saved the patient by giving a proper diagnosis, proper treatment, and referring the patient to the correct person. So I usually take minimum of 2.5 years, because in India, you cannot prolong for a long time. Maximum time allotted by the patient is 2 to 2.5 years. But we follow all the steps, whatever possible. But on the textbook wise, if you see, minimum time they ask is 3 years. But I usually take only 2 to 2.5 years. And I am a great fan of mini implants. So I do a lot of mini implants. So that shortens my treatment time. So any other doubts are there, doctor could ask, and I'll be happy enough to do my presentation. And since we had a short time, now it's 12 o'clock in India. It's a Saturday, so all are happy. My family is here. So usually our bedtime, to be very frank, is everyone sleep by 9 or 9:30. But this was a very good Dr. Meron and EDPA. All the doctors whom I communicated with have shown great interest. And I'm very happy to listen from Dr. Meron. What she said is that we have been eagerly waiting for your lecture. So that's a very good positive note that I first got from her. And any other doubts are there, you could certainly post into the group. Stay, if possible, enter into the clinical tip group. Do good orthodontics. That's the first thing. Whether you join for the program or not, that is secondary. But do good orthodontics. Learn orthodontics, learn the mechanics, biomechanics, proper diagnosis, treatment plan. This is a one-time treatment. Do orthodontics like that. This is a one-time treatment. I am going to do the best to my patient, to my orthodontics. That means you have to give the best. That's a part of dentistry. Let be working in India, let me be working in Ethiopia or anywhere in the world. We are having a noble profession. Being a dentist, we will tell it's a noble profession. We can relieve the pain. We can do give a aesthetic smile. That's the best part of a dentist. We are provided or we are doing a noble profession. So since you are given a noble profession, don't hesitate to give the best of that profession. So if you want to upgrade, don't sit back. You keep on upgrading so that you are providing better and better treatment to your patients, and that's the first thing that God has given you a blessing. So you are given a noble profession, upgrade maximum possible so that your patients will get the maximum benefit of it. So I will time being, since I hope that everyone are through with your doubts. I'll be posting the clinical tips again from tomorrow. So back to EDPA, I'll go to the moderator, Dr. Bennett. Anything to conclude? You can finish it off. Now it's correctly almost 3 hours up. So we will be happy to wind up, I guess.
Okay, thank you. There are no more questions. It was a very lively and engaging session. So we want to do a very special thank you for our distinguished speaker for generously sharing your time, expertise, and clinical insights. This has been a very
Please.
informative, and we appreciate the knowledge you've passed on. So to all our attendees, thank you for your active participation and thoughtful questions. We hope today's discussion has provided you with valuable takeaways. So the attendees can take the exam to get the certificate. The link will be posted on EDPA's Telegram channel. The topic for next webinar will be posted on Sunday night, and you can register from Monday onwards. Until then, thank you once again, and have a great week.
Thank you, doctors.